Well, first I'd like to welcome everybody here. This is a great crowd. We have about 120 health professionals registered, and we would like to thank you all for coming. This is going to be a great training day for Alzheimer's disease. And I'm Judy Metcalf. I'm the director of the University of New England Maine Geriatric Education Center. We're one of 45 federally funded, HRSA-funded geriatric education centers in the country. And we also have received a supplemental funding award from our federal funder, from HRSA, to provide Alzheimer's disease and related dementia training to Maine's health professionals. And this will be the fourth Alzheimer's disease training that we've done. We did our first in Freeport back in March of 2013. We did our second in Bar Harbor this time last year. And we did our third in Presque Isle in October. In Presque Isle, we had over 170 people there. And then this is our fourth for our supplemental funding award. So over the course of our 4 trainings, we will have trained about 500 or so health professionals here in Maine, so that we welcome you. And this is a nice venue to get the word out. We have fabulous speakers, and I think it will be a very robust day. It will be fast-moving. I will forewarn you. If you have questions, please ask, and we will proceed. I'd like to thank our many sponsors, of which we have many. We have the Maine AHAC Network, the Acadia Hospital, the Geriatric Mental Health and Neuropsychiatry Program. We have Maine Coast Memorial Hospital. We have the Elder Investment Fraud and Financial Exploitation, our EFI group. We have the Eastern Maine Home Care, and we also have the Lunder-Dineen Alliance of Maine. And Lunder-Dineen has been an especially generous partner, and we are very, very pleased to have them as a sponsor for us again this year. And just to use the opportunity to share with you a bit about Lunder-Dineen, if you're not familiar with them. They are a health education program that seeks to address gaps in health education across the state for Maine healthcare professionals and the communities they serve. And we, as our GEC, we are very fortunate to have had Lunder-Dineen first join us as sponsors in last year's event and again this year. Lunder-Dineen also recorded last year's keynote presentations and developed free 4-credit webinars that you can find on their website. At this website address. And Lunder-Dineen is also collaborating with UNE on an oral health education project for health professionals and residents of long-term care settings. So please look out for more information from Lunder-Dineen. You can go onto their website, you can access their programs, and their programs are fabulous. This is a nice collaboration and a nice opportunity for Maine's health professionals to yet continue to advance through continuing education. Also, all of the training materials that will be presented here today, you'll find on our website, or this website, if you will. Access here. You'll be able to download the presentation. I would also like to thank all the folks, and there's been many that has helped our GEC to bring this program to you. And they include Nina Bennett, who many of you have been receiving emails, like 60 from Nina Bennett, who is the Alzheimer's disease training coordinator for our Geriatric Education Center. Also Marilyn Amoroso, our office manager, and Jerome Bennett and Bob Metcalf, who are volunteer registration folks this morning. We also thank UNE CME Department, Doreen Merrill and Suzanne Levine, and we have a special thank you to our UNE IT, Dave Dadiago, and Carl Kerrigan, who have wonderful IT expertise and keep us on the straight and narrow. Also to the Atlantic Oceanside event staff, and a special thank you to our CART specialist, Sherry Majeski from Minnesota, who is providing our captioning services. So you might hear from Sherry today a little bit. You might have a chance for her to say hello, but we'll see. Just a few housekeeping components. Everybody should have received a packet of material as you came in. With your agendas, your evals, there's a GEC tracker there, which we ask everybody to fill out if you could. Our HRSA funder would like to know the demographics of the folks that we train. So we ask you kindly if you could complete that form and return it at the end of the day. For those of you who have requested CME, there's also a CME form in your packet. And in order to receive CME, it's very important that that form be completely filled out and returned to us at the end of the day. And then we will provide this to our CME department, and then they will send you your CME certificate. But without that completed form, they won't be able to send you your CME. At the end of the day, we would ask everybody if you could go out the door next to the registration table. And you can put all of your sundry handouts, any of your evaluations and paperwork, you can leave it on the table on your way out. So that would be appreciated if you would head out in that direction, in that door. There's many doors here, and I get confused walking around. I'm never sure which door I'm coming in and where it's going to bring me. So we've tried our best to provide adequate signage, and we hope that this helps, but I will say that there are many doors, and so please bear with us. The breakout sessions, also in your packet, you'll notice that there's a request for those of you who would be gracious enough to provide us with this information. It's a request for a 3-month follow-up for us to be able to email you and ask you how you have used this information in your clinical practice. So that if you are willing, if you could also sign that form and return it to us at the end of the day. The breakout sessions are located in 3 different places. There will be a breakout session in this room. There's also there's 2 breakout session rooms on the first floor. And I'm just going to tell you quickly where the different breakouts are so you'll know, so we can decrease a little of the confusion. If you look on your agenda from 11:15 to 12:15, the first breakout session, evidence-based pharmacology, is in the Town Hill room downstairs on the first floor. The early onset dementia and intellectual disability is here in the Bass Harbor room, and geriatric screening for office practices is downstairs on the first floor in Seawall. This afternoon's breakout sessions, the first one, Effie, is in the Bass Harbor room, which is this room. Communicating with caregivers is downstairs on the first floor in Town Hill, and the advanced care planning is also downstairs in Seawall. Hopefully that will make it a little bit easier for you. And just another few quick notes. We will ask that everybody sign an attendance sheet for each one of your breakout sessions, just so we know who attended which breakouts. And from 12:15 to 12:30, we'll gather for lunch. There will be tables set up in the back of the room. Lunch will be, as you can see, in the circular tables in the back. We will ask people, if you can, to go quickly through the lunch lines and then choose a table, because from 12:30 to 1:30, there'll be a panel discussion. So essentially, it gives us 15 minutes for everybody to gather their lunch, have a seat, and then the panel will begin. And then everybody should come back into this room for Dr. Mary Sano for her session. Restrooms are to my left, in back of the registration table. There's also restrooms on the first level. And I think that's it. I think that's enough. All right. We'd like to welcome our very first speaker, Dr. Larry Rumuno. And Dr. Rumuno has a brand new position. He's the Chief Medical Officer at Sibley Memorial Hospital for the Johns Hopkins Health System. Formerly, Dr. Rumuno was the Senior Vice President, Medical Director, Care Management and Integration at the BI Deaconess Medical Center in Boston. Dr. Rumuno also has served as Program Director and Operating Officer for the Quality Improvement at Northeast Health Quality Healthcare Quality Foundation in Dover, New Hampshire. And previously, he was a primary care physician and geriatrician. Dr. Amuno has also been medical director at the nursing home at Conway Family Medicine, Saco River Medical Group in Conway, New Hampshire, and we welcome Dr. Amuno.
I've been asked to try to give some framing for healthcare reform, and I'm going to share with you sort of my experience with it as it's integrated over time and as it's played out in some areas of the country. And I now have 3 experiences, somewhat in northern New England, in Boston, where it's, I would say we're on the bleeding edge, and some people are going to survive and some people aren't, and now in the mid-Atlantic area. So I start this from Lewis Carroll. If you don't know where you're going, any road will take you there, because I think there are a number of people in the country who think that healthcare reform came out of nowhere. And that's just not the case. It actually was seeded quite a long time ago in the late 90s. So let me just start with a few sobering facts about healthcare that most of you know but may not have seen together in context in sequence, and they give us a clue to where we're at today. I want to first mention these 3 reports from the Institute of Medicine. To Err as Human, which came out in 1999, Crossing the Quality Chasm in 2001, and Leadership by Example in 2002. Now, just out of curiosity, is there anyone in the room who's read all 3 of them? Anybody who's read 2 of them? Roger. 1? Okay, couple ones. So this is the roadmap. And let me just remind you, the Institute of Medicine is a group of private physicians that advise Congress. They are not employed by the government. These reports set the stage and basically told CMS how to create reform. So in To Err as Human, they conservatively estimated that the healthcare system essentially bumps off somewhere between 50 and 100,000 people a year, in addition to costing us $17 to $29 billion annually, and those are in 1995 dollars. And when this report came out, it effectively met with a yawn. No one did anything, really. And simultaneous with this report, a bunch of studies were published, which one would have thought would have woke up the medical community, but they didn't really. McGlynn and her colleagues at RAND published this article in the New England Journal. It was the lead article in the issue. And their quote says, this is a summary, they analyzed over 400,000 clinical experiences. And our results indicate that on average, Americans receive about half the recommended care processes that they should get. And actually, having seen the raw data and talked to the analysts, this is actually a very generous description of what they found. They weren't actually allowed to write what they found because it was too damning. What they really found is when you looked at a constellation of performance by disease state, Americans got less than 10% of what they should have gotten. And what I mean by that is they asked the question, if you were a diabetic, did you get your glucose test, yes or no? Or did you get a flu shot, yes or no? And that averaged out to about 50% of the time people got all of those on average. But for a diabetic, they really do better if they get all the things they're supposed to do. And when that happens, that rate's somewhere in the single digits in the United States. And it remains there today, actually. There was a number of publications looking at the performance of the U.S. healthcare system, frequently noted by our congresspeople as the best in the world. When you objectively look at it, it's actually among the worst in the world. In addition to that, we were spending an incredible amount of money, and what's a lot? Well, here's the per capita spending of the United States versus the rest of the first world. And you can see on the left-hand side of the graph, things are getting a little out of control. And when you compare it to total GDP, it was broaching in 2005 at 16%. It's now at 17.5%. But this past year, it actually looks like for the first time in recorded history, it may actually start to go down. Another point that I think really hits home for everyone in this room and for the patients we take care of. This graphic looks over the decade from 2000 to 2007 at a bunch of things that are sort of very practical to your pocketbook. The top line is net cost of private health insurance administration went up 100% over those 8 years. Family health premiums went up almost 100%. Personal health care not covered by insurance went up 65%, but workers' wages only went up 24%. And it really was getting to the point where people were choosing insurance or food. And there's many places in Maine that those are the choices being made. This looks at percentage of health expenditures, just a snapshot in 2006, just to understand where the money's going. So about a third, or 30% of the money goes to hospital care. About 20% of the money goes to physician services. And then it drops significantly, 8% to nursing home care, 3% to home health care. Now, you might sort of scratch your head and say, that seems like nursing home care seems sort of expensive. Well, remember, this is total health expenditures for the entire population, not just the geriatric population. So to think about it, essentially, everyone in a nursing home is a geriatric patient, or practically. And 8% of the dollars is going to the population over 65 just for nursing home care. Most of that, Medicaid. The other thing that was happening over this period is that we had a volume-based payment system that was driving particularly hospital and physician care, but others here, to behave like economic actors in the economy, just like everyone else. That is, the more you did, the more you got, regardless of what you produced. There's basically no governor on how well the care you produced. And it was demonstrated over and over again that this was creating, initially people denied it, but that's just not really what's going on. Here's just a simple example. Physicians or doctors who own cardiac stress machines are more likely to order heart tests. It's not a big surprise. Physicians who own or bill for nuclear cardiac technology were twice as likely to order the procedure as those who aren't paid for it, according to a study published in the JAMA. And this went on across almost every test in medicine it's been looked at, whether it be a cardiac test, whether it be a procedure, and it was even true in the procedural specialties where you would think, the physician has the choice about whether to perform this procedure, and the patient, they're supposed to be acting in the patient's best interest. Well, the fact of the matter is that when it's equivocal and they can generate revenue from it, they generate revenue from it. Now, does that make them bad? No. They're just economic actors like everyone else in the economy. Just too long people believed that they were special or different. They're just not. In this data from 2013 tells you something very interesting that was simultaneously going on with this. More than 90% of Americans think that choosing a physician or a hospital is the top of significant life decisions. But most spend more time selecting a new car than they do selecting a physician. So 42% spend 10 hours or more researching a car, but 34% or spend less than an hour researching a physician. And the reality is researching means calling your friend and asking them whether they like Dr. X based on absolutely nothing. I used to get asked all the time, and I'm sure Roger's sitting here, you get asked all the time, should I go to Dr. X? I don't know. I have no data to base it on. Even my referral experience just isn't enough data to decide whether it's a good decision or not. Now, the people, my guests beyond 20 feet can't see this, am I right? All right. So I'm going to point something out here because, so I said that the three reports from the IOM set the foundation for healthcare reform. The data that's on this slide and data like it set the context and the target. And what I mean by that is this is data from the Dartmouth Atlas for Healthcare. John Wenberg and his colleagues at Dartmouth in the early 90s, and we were fortunate enough at the QIO to build the first workstation that they worked on, started looking at variation analysis across the country using Medicare data. And what this slide shows is that at the lowest quintile of spending, so they divided the Medicare spending into 5 groups, just more and more spending. The more you spent, the less performance you got. On every metric here, and this just happens to be the topic of acute myocardial infarction and some preventative care, so AMI is at the top, preventative care is at the bottom. As you go across from left to right, the spending goes up and the performance on the metrics go down. Now that doesn't seem to make any sense, does it? And you look at this over and over. You look at it for pneumonia care. You look at it for surgical care. You look at it for nursing home care. Same thing over and over and over again. And somebody finally started to say, wait a minute, this just doesn't make a lot of sense. And unfortunately, the other real problem is that the 4th and 5th quintiles are really concentrated in states of significant import to the United States because of their populations. I've been noted to say, and I'll say it again, God forbid you live in a state that touches the Gulf of Mexico, because they're all there. Every time you look at a Dartmouth map, all the high cost, low performing states are all in the southeast of the country. No matter what metric you look at, it doesn't really matter. And when you look internationally, this is an overall ranking of the OEDC first world countries by various metrics, whether they be quality care, access, timeliness, efficiency, equity. And on the far right-hand side, next to me, you can see the United States. On virtually every metric, they're at the bottom of the pile. Now, you might be a little surprised that we were in the middle of the pack for patient-centered care. And I'm a little surprised about that too. But the country right next to it, the United Kingdom, at the bottom of the list, that's because they use evidence-based care and they don't let people complain about, well, I'm waiting for my bypass surgery. You wait. You don't need it. Another perspective is the cost of a very long life. This is a graphic that shows various countries across the bottom and average life expectancy. And as you can see, the life expectancy drops from left to right, and the cost drops with it, except in one notable exception, the United States, whose cost is above everybody. So the overwhelming theme here is we have lots of errors, we make lots of mistakes, we don't deliver the care we know we should deliver, and the more we spend, the less we get. Now, at a certain point, somebody's going to wake up and smell the coffee. The IOM woke up and smelled the coffee and wrote those reports. And they said in the first report, you'll find, in 1999, we have an unsustainable increase in spending. The costs are driven by technology that don't improve outcomes. There are large variations in clinical care where the evidence is unclear. And there are some uncertainty about some best practices in very common conditions. So these 3 reports, again, set the framework. I bring this back up because finally in the 3rd report, Leadership by Example, the one most people, I've never met anyone actually who read it, they finally gave up and put something in the first recommendation. And I want to point out again, this is the Institute of Medicine and a bunch of private physicians. They said this: the federal government, this is 2002, should assume a strong leadership position in driving the healthcare sector to improve the safety and quality of healthcare services among the approximately 100 million beneficiaries of the 6 major government health programs. So this is Medicare, Medicaid, the Department of Defense, the VA, been in the news recently, SCHIP, and the Federal Employees Health Program. Those 6 programs cover 1/3 of all Americans. Given the leverage of the federal government, this leadership will result in improvements in safety and quality for healthcare provided to all Americans. So there's a bunch of private docs telling the government, force it to happen because we've asked the private sector and they're not getting the job done. So CMS took them at their word. Just for context, CMS is the largest purchaser of healthcare in the world, not just in the United States. That part of that's because we're so expensive, but the combined Medicare and Medicaid pay approximately 1/3 of the national health expenditures, $800 billion a year. The program currently provides coverage to 105 million beneficiaries. It pays out $1.5 billion in benefit payments a day. Through various contracts, CMS processes over 1.2 billion fee-for-service claims and answers 75 million inquiries annually, and millions of consumers will receive health care coverage through the new Insurance Act authorized under the Affordable Care Act and have already. And I'll point out, every time a survey happens, the #1 rated health plan in the country, far and away, more than 10 percentage points at every question, Medicare. And they do it at an administrative cost of less than 1%. And in the private sector, the administrative cost is 17.5%. So CMS began working on the constructs or the underlying issues of a national quality strategy, but they didn't actually get around to writing a document until last year. So until last year, we did not have a national quality strategy in the United States, or 2 years ago. And it's framed on these 3 principles: better health for populations, or better care, better health for populations, and affordable care. And the Affordable Care Act is structured around these 3 areas. So specifically, better care is to improve the overall quality by making healthcare more patient-centered, reliable, accessible, and safe. So most of the work in this area and most of the regulatory or incentive issues are around these 4 topics. All 4 of them specifically will touch the Alzheimer's patient, as an aside. Improve health to communities, improving population health by supporting proven interventions to address behavioral, social, and environmental determinants of health. And as many of you know in the room, the healthcare system really doesn't, or historically has, and never really looked at this. It just sort of, we know it exists, and we sort of ignore it. So the Affordable Care Act in a number of areas actually attempts to address this, as does the CMS National Quality Strategy. And under affordable care, reduce the cost of quality health care for individuals, families, employers, and government. And frankly, this is the one part of the Affordable Care Act that it doesn't specifically address. If you look at it carefully, and people have commented, there's not really any cost controls in it. And there isn't. So then why is healthcare spending slowing down? Or maybe even decreasing? Well, the real issue is that the Affordable Care Act puts all the money on the table. Heretofore, it's been invisible. 20% of the dollars being spent are not covered, people are not insured, and no one sees the expense. It gets hidden. The Affordable Care Act forces all of the money to be on the table, and suddenly people are starting to realize, wait a minute, we can't afford to do all this. There are 6 major priorities in the CMS quality strategy, making care safer by reducing harm, ensuring each person and family are engaged as partners, promoting effective communication, promoting effective prevention treatments, particularly around cardiovascular disease, since the evidence there is the strongest, working with communities to promote wide use of best practices to enable healthy living, and making quality care more affordable using various spending models, which I'll touch on in a minute. These are laid over 4 foundational principles: eliminating disparities, which including economic, which are still profound in the United States. Economic disparities, actually there's only 3 states in the country where you can't, outside of economic, at least for racial disparities, you can't find them. Maine, New Hampshire, and Vermont. As a matter of fact, when you look at it, the underperforming population is the Caucasian population. So kudos to the providers in those states. There's a goal to strengthen infrastructure and data systems. You're starting to see that. The most notable thing that you're probably aware of, that you've heard in the news, is when CMS released the physician payment data about a month and a half ago. So they've had that data forever. It's never been public. It's now public, and it created quite a stir. So transparency is the name of the day. There's a goal to enable local innovations and foster learning organizations. So these are just the 6 goals. So one of the goals is around patient engagement, and I just want to take a minute to talk about the construct of engagement, because many people, in my experience, don't really understand patient engagement. What they think about it in terms of satisfaction, and engagement is not satisfaction. Satisfaction is a small piece of engagement, but specifically engagement refers to your patients and or stakeholders' investment in or commitment to your product or brand offerings. How do they recommend you to others? Do they keep coming back? It's based on your ongoing ability to serve their needs and build relationships so they will continue using your products. Now, in healthcare, we generally don't think of care as products, but the reality is we are serving patients and we are charging for it, and they are buying our services. Characteristics that describe engagement include loyalty, their willingness to make an effort to seek healthcare services with your organization, their willingness to actively advocate for and recommend your organization and healthcare service offerings. This is a different way of thinking, at least in my experience in healthcare. We don't think about that. But if you're actually as good as you think you are, and you can engage patients around it, you'll actually improve your performance, both with patients and your financial performance. Now, if you're trying to think of a model of what engagement might look like, well, let me just show you. It's right here in my pocket. Apple. They engage people. People actively advocate for their products. They actively go out and tell people, this stuff's great. It changes your life. And when you find healthcare organizations that have engaged patients, as I've had the privilege to visit as part of being a Baldrige examiner, people who score at the 99th percentile in patient engagement, they're different places. How they take care of patients is different. The patient's experience is very different. There's a number of things in the National Quality Strategy that are going on that CMS is implementing. There's the Partnership for Patients, of which I saw there was a handout about choosing wisely, that's actually a piece of the Partnership for Patients through the American Board of Internal Medicine. There's a multi-payer advanced primary care demonstration projects, the Million Hearts campaign, the patient's experience and patient engagement in value-based purchasing that CMS is now paying on beginning last year. There are community transformation grants. The CMS Innovation Center has 21 initiatives looking at various new delivery models. and the National Quality Strategy has informed the current QIO program contract, which is the next contract's about to start in August. There are some embedded things in the National Quality Strategy having to do with measurement. Measurement is not something that healthcare has embraced till very recently, and I'm not sure they've completely embraced it, but again, if you don't know where you're going, any road will take you there. If you don't really know how you're performing, everybody thinks they're great. So there's various reporting programs across Medicare and Medicaid. Almost no one now is not reporting. There's the hospital quality program that Medicare and Medicaid use. There's the physician quality reporting system. There's the post-acute care and other quality sitting reporting systems for long-term care and home health. There's a payment model reporting around performance of the ACOs. The ESRD networks are now paid for on a performance basis. All of these payments right now are small fractions of the overall payment, but it's just a matter of time till they become a significant portion of the overall payment. The Sentinel event that started this whole payment and changing behavior actually occurred in the mid-2000s when CMS needed reporting or wanted to have reporting data on hospitals. They worked with the American Hospital Association and asked the American Hospital Association if they would work with hospitals to report data to CMS. CMS posted 10 measures and said, we'd like the hospitals to report. The AHA said, we'll help. Frankly, I don't think they helped very much, but anyway, so there were 5,500 hospitals in the United States. At the end of a year, only 410 hospitals reported any data. No hospital reported data on the 10 measures. And let me tell you, 6 of the measures were on acute heart attack. So the then administrator of CMS, Tom Scully, in a famous statement posted on the CMS website said, time to go to Plan B. You want your pay raise next year? No problem. Just give us the data. You don't give us the data, no pay raise. 10 months, 5,500 hospitals put data in that. There wasn't a hospital in the country that didn't submit data. I warned people at the time, if you're a policy wonk and you see this happen, that's never happened in U.S. healthcare before. You think they're not going to do it again? They're doing it again, and they're going to keep doing it. The measures are becoming aligned across all domains in healthcare. They're across all healthcare sectors, and there's the adding of patient outcomes and patient experience measures, patient engagement measures, and an alignment in the private sector with the National Quality Foundation, and also re-credentialing organization experiences the physicians have to report for credentialing. CMS's goal is to have a parsimonious set of measures and not completely bury people with measures. On the other hand, initially when measures started, people said there's a lot of them. I don't know, if you were in GE and you were looking at the performance metrics on their engines, you wouldn't think there were a lot of them. You'd want all of them to make sure the engine was still spinning when you were in the plane. This is a framework. It depicts the framework and the activity within each area. So, for example, in the top left, clinical quality, CMS is focusing on primary care and cardiovascular measures, prevention measures, and setting and specialty-specific measures. And you can go around the various topics here and see the various types of measures that CMS is attempting to put out there. One comment about measures in general, there's something called the National Transfer the National Technology Transfer Act. It wasn't designed for healthcare. It actually was designed for other things like standards in the internet and stuff. But the National Technology Transfer Act says something that's very important for healthcare. If a consensus body decides on a standard or a measure or a structure. And a consensus body in healthcare is the National Quality Forum. They go out of their way to make sure they meet the definition, which is long and complicated. And they approve those measures. Then the government, there's two parts of it. The government has to use those measures unless they can come up with a compelling reason not to use them. And for the most part, CMS has used them. There's been only a few instances where they haven't. The second part of the act that people don't pay much attention to is it also says that they can enforce it as a rule. They can use it as a law, essentially. And that, I will just tell people, that time's coming. For people who don't respond to the payment mechanisms that we talked about, at some point, CMS is going to enforce performance based on the measures, because there'll be laggards that don't want to change. I mentioned these cross-cutting items already. I made reference to before these new payment models. Let me just touch briefly on the 4 sort of categories of payment models, just to make you familiar with them. So there's value-based purchasing, of which hospitals have been under the experience of for now 5 years. It has changed performance for hospitals dramatically. Basically, their pay raise is at risk for not getting performance, and they are incentivized to have higher performance. And those areas of performance started with pure clinical measures. Patient measures were added in. So there were clinical process measures, then patient measures were added in, then patient outcome measures were added in, then specific measures around disparities were added in. And actually the process measures have dropped in weight and the outcome measures have gone up. And there's been a march to focus on patient outcomes, patient experience, and specialty population measures. There's demonstrations right now in long-term care and home health, and I would expect within the next year, actually, that value-based purchasing will come to those settings. There's also a demonstration that I think is going to roll out in the next year for physicians, too. The second issue is around non-payment of unwanted outcomes, the development of CAUTIs or fractures or readmissions. And CMS currently doesn't pay for patients who get readmitted with catheter-associated urinary tract infections or who have fractures in the hospital, and they penalize hospitals for readmission rates that are above predicted levels. And that, at least in some places of the country, has changed behavior dramatically. There are PCMH demonstrations, patient-centered medical home demonstrations going on that are being funded, and actually just last week, a large trial demonstrated that patient-centered medical homes that use electronic records improve performance of patients and improve patient outcomes. And finally, the shared saving models, which a broad form is ACOs, or there's disease-specific ones. ACOs are structures of which that are forcing healthcare organizations to pay attention to the whole patient. And as, if I get this right, Roger just shared with me a tagline he has, which is, geriatrics is healthcare reform. Geriatrics is where all the patients' money is being spent, and unless you figure out how to manage them, you're not going to survive or succeed in this environment. So what does this have to do with Alzheimer's disease? Well, let me just step through the national quality strategy goals and tell you, I think, from my perspective as a physician and geriatrician and as a healthcare administrator, what I think it's going to have an effect on. These are the 6 goals, but making care safer. Safer care benefits this population that's at particular risk to exposure to unsafe care for a multitude of reasons. So making care safer could be as simple as avoiding rehospitalization, or for that matter, avoiding hospitalization at all. The vast majority of time, there are people that get readmitted to the hospital And these could be avoided, despite what people sometimes say. I was talking to Judy before the meeting. If you walk into the Beth Israel Deaconess Medical Center emergency room today, what's your chance of ending up in a bed? Anybody want to take a gander? 25%, 20%, 49%. You'll either be observed, or admitted to an observation bed in the ED and stay there for more than 8 hours. Really? This is a community hospital, folks. I mean, it's a community hospital. And the reality is that they don't think about the patients. Once the patients leave their doors, they don't think about them. And so to feel secure themselves, they keep them because they think that it's safer to keep them. We all know it's not safer to keep them. So making care safer, I think, specifically addresses the Alzheimer patient. This environment will help them. Ensure patients and family engagement. Well, this one, to me, for people in the room, I don't need to tell you, this is obvious. If we actually force healthcare providers to pay attention to patients and their families and meeting their families' needs, the patient's going to do better. Promote effective communication and coordination of care. So minimize transitions of care that lead to delirium on top of their dementia, and improve care coordination and communication regarding care. I think you're going to see even a larger set of measures and set of performance metrics and financial things about this. Crude readmission rate to hospitals is sort of a large sledgehammer to work on this problem. It's trying to get people attention. It's built in the ACO performance measures, but at least in my experience in Boston, trying to get people to realize that they actually can affect this is tricky. Just as an example, while I was at BI, I managed to convince the area on aging groups in Greater Boston, which are called, I'm drawing a blank. They have a different name in Massachusetts and everywhere else in the country, but basically there are three of them in the city of Boston. I managed to convince them to come to the hospital and see patients who might be eligible for their services before the patients went home, on their dime. They thought that was a great idea. When I told it the administration, I got, oh, that's interesting. It's interesting? Okay. So it's going to take a while for people to understand that we can really make a difference in how patients are cared for. Promote effective prevention and treatment. This actually, for this population, I think specifically gets to treating them medically less. There are a number of patients in this population, and you're going to hear it today, who get, quote, treatment that probably isn't effective, but they're getting treated because someone wants them to do something, and they think doing something is better than doing nothing, when the evidence is probably pretty clear that that's just not true. And promoting best practices for healthy living, supporting the family so that they can support the patient. Some advanced ACOs are really thinking about this and really thinking about how to support the family. I will tell you where I'm going. I'm actually starting on Monday. We're opening the Hopkins Health System Innovation Center at Sibley Memorial. Sibley actually also has on the grounds a full spectrum assisted living, long-term care, rehab, locked dementia unit. And this is actually one of the things we're going to be working on to innovate how we can better support the family, to support the patient. What are the other things we can do to make the family more functional for the patient? And making care more affordable, as I said, as we get all the costs on the table, people will realize that we're doing a bunch of stuff that won't make a difference. So finally, the ACA has and will change healthcare as we know it. Um, Whatever happens in 2016, whatever that is, it doesn't matter. The game's over. The ball has already started rolling down this hill. Every private plan project that has used ACO work has caused a decrease in cost. The private plans are not going to turn back. The National Quality Strategy is a roadmap, and CMS will drive the change through every lever they have in its toolbox, because if they don't, they'll become irrelevant. Global payment mechanisms have and will further reduce costs and improve performance. Care will shift to be supported to lower overhead environments, which out of necessity will engage families. What do I mean specifically about this? I mean, one of the things we should be doing, and I'll tell you at Sibley we will be doing, is admitting people to their house. Because unless they go to the ICU, most of the stuff that's provided in the hospital could be provided in their house. You might think I'm crazy. There's actually 10 randomized trials that demonstrate you can do this. It's actually safer, better performance, at lower cost, and leads to higher engagement of families and higher satisfaction of caregivers. The first time it was done was at Hopkins in the late 90s, and I think it's where things are. And people with chronic disease will get focused on, at the very least, because that's where the cost is. And finally, patients with Alzheimer's disease will benefit because of these various topics. So I'll just stop there. If people have any questions, feel free to ask. Thank you for having me.
Thank you, Larry. All right. Our next speaker is Dr. Clifford Singer, and Cliff is the chief of geriatric psychiatry at Acadia Hospital and Eastern Maine Medical Center in Bangor. He is also an adjunct professor at the University of Maine in Orono, and he is certified by the American Board of Psychiatry in Neurology and General Psychiatry and Geriatric Psychiatry. In addition, Dr. Singer has been voted to the Best Doctors in America list every year since 2003 and has made national television and radio appearances speaking on topics related to aging. Dr. Singer and his Acadia Hospital team, along with the Clinical Research Center at Eastern Maine Medical Center, run the only active clinical trial program in Maine for experimental medicines for patients with Alzheimer's disease. Dr. Singer.
I'm going to open up with a brief history of present illness and review of systems. The history of present illness is that I've had several bouts of vertigo lately. I think I'm developing Meniere's disease. The review of systems is that I'm a little wobbly this morning. So the treatment plan is, if I go sideways, I'm not having a stroke. I'm just having an interesting neurosensory experience. I'll right myself quickly. And I won't eat salty food the night before I have to do something like talk or walk. So I'm going to talk about, while holding onto the podium, the assessment and differential diagnosis of dementia. I'm going to show you a brief overview of clinical practice guidelines for the assessment of dementia and review clinical aspects of diagnosis in the clinic and treatment. I think it's worthwhile coming back to our state plan, which has been out a couple of years now. But state plans tend to get forgotten after they're published. And how many of you knew we had a state plan? Good, that's a fair number of people. We also have a state plan for aging, and these documents really do provide valuable roadmaps. And as I say, I think it's useful to come back to them every so often to see how we're doing, because each of us has a role to play in advancing the priorities of the state plan to meet the need. And the need, as you know, is growing substantially. We're expecting a near doubling of the numbers of people with Alzheimer's disease between 2010 and 2030, we're already seeing the trend expressed in our day-to-day work in emergency rooms and hospitals. The system is already overtaxed by the demands of dementia care, and just going to get worse. These data show expected increases in population numbers of people at highest risk for dementia, and declines in the percentage of population of people who are available to provide the care. This curve shows that decline in younger people relative to older adults who need care. By 2020, there will only be 2.7 young people per older adult. That's not very many. We're, I think, third in that. Although we're the oldest state by median age, we're third in the number in this ratio. So the Alzheimer's Association has an official policy of encouraging people capable of procreation to go home and create little caregivers. Is Bill here? Did he hear me say that? I hope. Oh, Lori's here. Oh. Well, it's a new policy if it isn't already a policy. So the goal the goals of the main state plan are to coordinate care across the spectrum of service entities, and the Department of Health and Human Services already has a grant to push this agenda along. But there are multiple other efforts underway, including what we're doing today, to promote screening and care within the medical community, especially the primary care setting. John Campbell, who will be here today and is speaking in one of the breakouts, created, I think, an excellent format for diagnosis and treatment of people with Alzheimer's disease and other dementias. And I don't think I can improve on it. It's really quite excellent. The state document, the state plan, is available online from the Alzheimer's Association, and you can download it and read John's excellent format for assessment and diagnosis. Now, there are several organizations have published clinical practice guidelines for screening and assessment of dementia. The American Geriatric Society does not recommend routine screening beyond questions about memory and function, especially IADLs, money management, driving, medication management, safety in the home. And if staff or family or the patient perceive any potential problem in these areas, then the recommendation would be to go ahead and do more formal assessments, assessing cognition with validated instruments, documenting which particular clinical domains are affected, memory, language, executive function, so forth, how these changes in cognition affect day-to-day functioning, when these problems first developed, and how or whether or not they have progressed over time, and then of course always ruling out other causes of cognitive impairment, such as an acute illness causing delirium or depression. Now, the Alzheimer's Association convened an advisory group of experts that came up with a slightly different recommendation. Their recommendation was to incorporate routine screening into the annual wellness visit, which the Affordable Care Act has allowed CMS to encourage and reimburse. The justification for routine screening is that many times, in various studies, 27 to 80% of visits, cognitive impairment is missed without structured formal assessment of some kind of memory and other cognitive functions, and that use of these instruments improve detection of cognitive impairment substantially. Use of an instrument will detect 83% of cases versus 59% of rate detection just on the basis of clinical intuition or asking simple questions about how you're doing at home, how's your memory, and so forth. So the Alzheimer's Association Task Force recommended a two-step process to screen with either a mini-cog or an instrument that you may not be familiar with, the general practitioner cognition assessment, to screen at the annual wellness visit. A positive screen or clinical suspicion of a problem should prompt the clinician provider to reschedule another visit in the near future to do more in-depth evaluation with an instrument such as the Montreal Cognitive Assessment or the St. Louis University Mental Status Exam. And I guess an MMSE, a mini mental state exam, probably should be on here as well. But as you know, the MMSE, which has been kind of the gold standard for screening and initial assessment for many years, is now is copyrighted and is being superseded by these instruments, the MoCA and the SLUMS, which are especially more sensitive for mild cognitive impairment. And then if a person seems to be impaired on these measures, then referral to a dementia expert or more detailed diagnostic assessment is warranted. So how do you proceed with history taking when you suspect cognitive impairment or have detected it on a measure of cognition, direct measure of cognition or function? Well, it's important to get the history. How is a person currently functioning, and what particular changes in cognition have been detected? Very important to ask, what was the first evidence? Was it forgetfulness, memory problems, or was it thinking and decision making? Or frequently, it's actually a change in personality and behavior that are the first symptoms of a degenerative process. Have the changes been gradual, or have they been fairly abrupt? Now, sometimes a gradual process can be so subtle that family or a patient don't notice it until there is kind of an abrupt change, either a vacation or a caregiver or a family member dying or going into hospital, or the patient themselves going into hospital. And there's an episode of delirium, for example, that first uncovers what has actually been a very subtle decline. So the family's perceptions of this may not be completely accurate. We frequently do get misled into thinking somebody is just delirious and may return to an independent level of function, but in reality, it's possible that they've been declining over in a progressive way for a longer period of time. Have the changes been stable over time, or have they been gradually progressive? That's helpful in the differential diagnosis. And then, of course, getting history about alcohol use, person's mental health, whether they've had TIAs or strokes, traumatic brain injuries, concussions, and then medical risk factors for dementia, such as hypertension or diabetes. And then I think it's important to ask about daytime sleepiness, obstructive apnea, or other causes of sleepiness cause cognitive impairment. The functional status is critical to the assessment. We undo many diagnoses of dementia because people may have a bad day on a cognitive exam, or they may have some mild cognitive impairment that affects their performance on a cognitive exam, but they're still quite independent and safe at home. So asking questions about ADL function and IADL function, or cognitive ADLs, is really a critical part of assessment, and determining whether cognitive impairment has reached the level of sufficient enough to call it dementia. these are the elements of cognition that should be assessed. Attention and concentration can be assessed with various tests like digit span or reverse sequences, spell world backwards, months of the year backwards, or serial sevens or serial threes, counting, for example, counting backwards from 100 by sevens, which is very, very difficult. That's a tough test. Or counting backwards by threes from 20 is easier. Even counting backwards from 20, 19, 18, so forth, it's a much easier test. Spelling world backwards or spelling a person's name backwards. Dr. Wireman at Maine Medical Center likes to use the word truck because it's easy to spell. Everybody in Maine can spell truck. And a person who's hard of hearing doesn't hear the word world very well. Don't you agree that sometimes that's a little tricky? I like to ask a person to spell their last name backwards, assuming it's not a four-letter word or three-letter word, short name. Months of the year is sort of intermediate, I think, between spelling backwards and counting backwards by sevens or threes. Orientation questions, date, place, time, situation, the nature of the encounter. Language fluency, verbal fluency, the ability to articulate well and the ability to produce words easily are key ingredients of, or early symptoms of cognitive decline. Visual spatial testing, the ability to copy designs or navigate around one's neighborhood or city. Simple calculations, and then assessment of judgment, insight, and reasoning based on the person's recent decision-making and their function. Now, I think as we go through life, we may experience forgetfulness ourselves or see forgetfulness in family members, and certainly in clinical situations, trying to figure out if the problems a person is experiencing is within sort of normal range. And these are my sort of completely unvalidated clinical impressions about what is normal and what is not normal. What is normal? Not remembering a person's name. What's his name? Obviously, unless it's a spouse or a child and you don't remember their name. But what's his name? What's that called? Where did I park? Where did I put those? Did I tell you this already? Yes. Did I ask you this already? Yes. Did you tell me this already? Yes. I mean, these are things that are most problems that we all experience based mostly on inattention, not paying attention, or just normal middle-aged to older age forgetfulness, problems with retrieving information that's previously learned. What's not normal? Well, the warning signs include getting lost in a familiar place, not being able to follow directions or a recipe, for example, that someone's been using for a long time, telling the same story more than twice without asking, I think within a couple of days. I don't know, what do you think? Is that reasonable? Asking the same question more than twice, I think we can give people 2 times. Losing interest in conversation, leaving home, losing interest in hygiene or other people. This is evidence of neurologic apathy, which is an early personality change of the dementias. Several organizations have early detection checklists. The Alzheimer's Association has a 10-item checklist for dementia, sort of worrisome signs indicating a person needs further assessment. So I would encourage you to look at those two. But these are kind of my standard reference points that I have in my head. Well, once you suspect that there may be a problem, moving on to a validated instrument is important. Fast instruments, so the mini-cog, 6-item screen, which is 3-word recall, 3-item recall and 3-item orientation, and the general practitioner cognitive exam, which is an Australian instrument, but it includes both a little cognitive test and questions for the family. So it incorporates a functional assessment right into a quick screen. That's why I like it. And it's why the Alzheimer's Association task force recommended it. More sensitive and diagnostic measures include the mini mental state exam, the Montreal cognitive assessment, and the St. Louis University mental status exam. Now, if you don't have a scale handy, I love it when residents or colleagues who are presenting a case to me, I don't love it actually, when they're presenting a case to me and they said, well, I didn't have time to do a formal mini mental state exam. Well, there's nothing really, just because you don't have time or you don't have the instrument available doesn't mean, don't feel bound to use an instrument. If you don't have an instrument handy or don't have time to use an instrument, of course the mini-cog is 3-word recall and clock draw test. You always have that available. So you could add orientation questions to it, and you have a good little screen. 3-word recall, clock draw, that's the mini-cog, plus orientation questions. That's a really good initial screen. If you add a verbal fluency task, how many animals can you name in a minute? You should be able to name 15 or 16 animals in a minute. When I moved to Vermont a few years ago, I first did an animal fluency task with somebody, and he started telling me heifer, Jersey, all kind of cows. He came up with like 12 different kinds of cows. So that was good. That was a good little. He passed. Serial 3s or digit span for attention, and then of course a family caregiver interview. So that would be perfectly adequate. If you don't have to feel tethered to a validated instrument if you do some kind of structured assessment. But the mini-cog is sort of the recommended quick screen in general practice. A 3-word recall and clock draw test. It's generally pass-fail. It's validated across cultures, suitable for screening, but I really would encourage at least adding orientation questions to the mini-cog. The mini-cog algorithm, I don't know if you can see this, but if you can't remember any of the 3 words, you have to. It's not that you're demented. You might be delirious, or just or inattentive. You may be sleepy or whatever, or intoxicated. It just means that you now need to be evaluated for dementia, or if the clock is abnormal in any sense, the circle isn't right, the numerals aren't correctly placed, and the hands aren't correctly placed. It just means those are signs that you need more further assessment. It doesn't mean you're demented, as in this publication. It just means that you need really an evaluation for dementia. If you can recall 1 or 2 of the 3 words and your clock is good, you've actually passed the screen. You probably don't need further assessment unless there is a concern of the family or some functional decline, evidence of functional decline. Yes, and then further assessment is necessary, because this isn't 100% in sensitivity. It's pretty good, about 70%. If you can remember all 3 words, then that's pretty good. But again, you pass the mini-cog, but it doesn't mean you don't have a problem. It is based on how you're functioning. This is the Montreal cognitive assessment. It takes 10 to 15 minutes, sometimes 20 minutes if a person is processing slowly. It is in the public domain. It has a fabulous website. It's available in literally dozens of languages. It's a superb instrument. It is education sensitive because there are questions, items on it that are sensitive to education, but most of these tests are. It's quite a bit more sensitive than a mini mental state exam. You can go to the website, you can download this instrument in several languages, as I say. You can download the instructions. It's really a superb instrument. This is the St. Louis University Mental Status Exam. It doesn't have the website support that the MOCA does. It's generally, you can download a PDF file of the St. Louis University VA Medical Center, the St. Louis Medical Center. A lot of people like this instrument. I like it, but I think the MOCA is better supported, much more evidence for it in the primary care setting. And it's available in many different languages, and the website is better. But the SLUMS is a pretty good instrument. The 6-item screen is includes time orientation, day, month, year, and 3-item recall. Just takes about a minute. Probably not as sensitive as an MMSE, certainly not as much as a MOCA. If you add the clock draw test, an animal or letter fluency, that's a pretty good ad hoc exam. So if you don't have anything available, you could do a 6-item screen is sort of, you can make it a mini cog plus orientation, plus letter fluency or animal fluency. Letter fluency is asking a person to give you words that start with a particular letter. And the letters that are most commonly used are F, A, and S. And of course, all the profanity words are included in this. So it's like, I don't know. So sometimes we use the word B, although you can think of profanity that starts with B too. But that's distracting for people, especially give me some F words when you ask them. You know, they just, it's like, really? I mean, that's a distraction, which is, you know, I think confounds the test. But anyway, those are the letters that are best validated. And again, a good performance is 15 or 16 words. Under 10 is typically quite impaired. And if you're assessing, say, somebody for frontal temporal dementia, they often cannot break 5. Under 5 is evidence of pretty profound frontal dysfunction. There are different measures of functional status, including the General Practitioner Assessment of Cognition I mentioned has both has both a cognitive component as well as a family interview component. There's a clinical dementia rating scale, which is really basically a research instrument that I think has great clinical utility. We use it in our program. There's also the functional assessment scale, and a number of other instruments that are suitable for functional, to remind you what to ask in terms of ADL and IDL assessment. Again, a critical part of the assessment. This should be the general practice cognition, the GP-COG. This also has a good website. I encourage you to take a look at it. It's in the public domain. It's an Australian instrument, as I mentioned, so it's got some questions that are sort of Australian in cultural implication. You can easily Americanize them. It's an excellent tool that not many people know about. This is an example. This is what you download from the website, and you can't see the specifics of this, but it will be in the slide set that you can download from the website. But you can go directly to the GPCog website and download the instructions and the evidence supporting its use. This is the clinical dementia rating scale, which you certainly can't see from where you're sitting, but this is downloadable as well, and it will be in my slide set, which you can download. It includes 6 domains of function: memory, orientation, judgment and problem solving, community affairs, home and hobbies, and personal care. And then these columns are no impairment, questionable impairment, mild, moderate, or severe impairment. And there are little descriptors in each box, which on average then would determine whether a person is functioning at the normal level. at the questionable dementia level or mild cognitive impairment or the mild, moderate, or severe dementia impairment. This is used in clinical trials as sort of the gold standard to determine when a person is impaired enough to be considered to have dementia, or whether the dementia is getting worse or staying stable. It's the sort of the gold standard of dementia severity. Along with scores on cognitive function, cognitive assessment, but this is real-world function. It's really where what really matters in terms of cognitive impairment and day-to-day function. This is the Functional Activities Questionnaire, the FAQ, which is another good, quick little assessment of IADL abilities. The ability to write checks, pay bills, assemble tax records, shopping alone for clothes, household necessities or groceries, playing a game of skill or working on a hobby, heating water, making coffee, turning the stove off, preparing a balanced meal, keeping track of current events, paying attention to, understanding, discussing TV, a book or magazine, remembering appointments, traveling out of a neighborhood, driving, arranging to take a bus or public transportation. So these are useful questions about whether a person is still safe to live at home or whether they're even impaired enough to justify a diagnosis. Now, neuropsychological testing is useful for when a person has very subtle impairment and you're not sure exactly what's happening. It's not, I think, necessary for most older adults whose impairment is detectable on, say, a MoCA or an MMSE, and the disease appears to be one of the more common dementias of old age. But if a person is relatively young or has sort of an atypical presentation in any way, a neuropsychological evaluation can be very, very helpful. As can an occupational therapy evaluation to really document what the person can or can't do, whether they can be safely left alone for periods of time or live alone. Any occupational therapists here? Oh, we got Dorian. Yeah. Oh, two. We use the geriatric depression scale to screen for depression or to evaluate the severity of depression. Of course, your clinical intuition is good too. The geriatric depression scale is valid down to an MMSE or a MoCA into the mid-teens. After a person has mild or moderate dementia, they're not as reliable in reporting depressive symptoms. So there are other instruments, especially the Cornell scale for depression in dementia, that is depends on your assessment and the family's report of depression symptoms. So, but for people, for normal healthy adults or people with generally intact cognition or only mild impairment, the geriatric depression scale is quite useful in screening for depression. The confusion assessment method, the CAM, is basically a diagnostic checklist for delirium. And of course, if a person has a more abrupt or acute mental status change, fluctuations in level of alertness or cognition, or disorganized thinking, diurnal variation in cognition, then delirium, certainly if there's an abrupt or semi-abrupt change in mental status, then delirium has to be considered, and there's some type of acute medical problem or group, several different subtle problems that are contributing. So just because a person performs poorly on a mental status exam, it doesn't mean that they're demented. It means that they're performing poorly, there's cognitive impairment at that point in time. But again, you have to put it into context. Is this an acute illness? Has it been a gradual change? Or you have to characterize it. If it is delirium, then of course you have to look for underlying cause, whether it be infectious, metabolic, medication-related, all the many causes of acute mental status changes. I like to use the Epworth Sleepiness Scale to screen for obstructive apnea, which might be contributing to cognitive impairment. This is an 8-item questionnaire which quizzes a person, or more likely the spouse, because we're not very good at reporting sleepiness, whereas our family is all too happy to to report on our failings. So this should be done, if possible, with somebody else also helping out. Whether the person is likely to fall asleep, when they're sitting and reading, watching TV, sitting inactive in a public place, as a passenger in a car for an hour, lying down to rest in the afternoon, sitting and talking to someone, or sitting quietly after lunch without alcohol, and finally in a car while stopped for a few minutes in traffic. And I don't know, if you're very, very sleepy, if you're very, very sleep deprived, it's not that hard really to nod off, just when you're stopped in traffic or listening to someone give a lecture, for example. And the score, if you score higher than 10 on this scale, it's justifiable evidence to refer for a sleep study, particularly if there's other evidence of obstructive apnea like hypertension. Well, we're talking about detection of changes in cognition that deviate from normal, and most causes of dementia, such as Alzheimer's disease, manifest as notable symptoms that might be considered variations of normal, but as they progress over time, they may justify a diagnosis of dementia, because cognition is generally fairly stable with normal aging, except for memory. Memory and time-based cognition does decline as you get older. But reasoning, thinking, and decision-making ability, judgment, wisdom, all knowledge tend to improve or at least stay stable over through aging until there's a degenerative disease. There is this hierarchy of age-related memory impairment, from age-associated memory impairment to mild cognitive impairment, where there really is quite significant problems with encoding new information, but still intact executive function, all the way to dementia, where there may be disabling memory problems or problems with reasoning and function. Alzheimer's disease begins in the medial temporal lobe, and that affects the hippocampus, and that's why encoding of new information becomes problematic. At this stage, which would be called pre-dementia Alzheimer's disease, there is a person may have impaired enough learning ability, new learning ability, to be diagnosed with mild cognitive impairment. And they have about a 12 to 15% risk per year of progressing to the point where they might be diagnosed with dementia, because what would happen is the Alzheimer's disease tends to spread into other brain areas, the parietal area and the frontal area of the brain, and to get worse in the temporal lobe, so that you start having more symptoms than just memory loss, and symptoms that affect your ability to function independently. The disease progresses to involve more brain areas and more densely affected in the temporal, parietal, and frontal areas, so that the dementia is progressing. So it's important to pay attention to this process and reevaluate patients who have mild cognitive impairment, because they're at high risk of progressing over time. It's generally recommended to retest them re-interview the family at like 6-month intervals is probably reasonable. Once the cognitive impairment is severe enough to interfere with day-to-day functioning, and this is a decline from their previous level of function, and it's not due to delirium or mental illness, then you start considering a diagnosis of dementia, based not only on cognitive testing, but again on functional status. Once you have this diagnosis of dementia, then some diagnostic thinking should come into play. We're not that great at distinguishing different types of dementia from one another, partly because they frequently coexist. There are, however, classical presentations of some of these conditions. The types of specific disease entities that you would consider in your differential diagnosis for people who have a gradual or progressive decline would be Alzheimer's disease, multi-infarct or small vessel vascular dementia, dementia with Lewy bodies, Parkinson's disease dementia, or frontal temporal dementia. I'll go into these in a little more detail in a moment. Secondary dementias may be due to traumatic brain injury, CNS infections, or alcohol. And then there are so-called reversible dementias, which may be due to medical or psychiatric causes. When I was doing my geriatric fellowship, we had a drug called Dalmane. How many people remember Dalmane? I actually had a patient on Dalmane the other day. Dalmane is an old sleeping medication, flurazepam, which has a half-life of about a week. So people would take it every night, and then the fog would come in. So we used to cure dementia all the time. Stop the Dalmane, stop the Dalmane. There were lots of drugs like that back in the day, of different types of barbiturates and Miltown and anticholinergic medications of various sorts. We still have to be alert for these things, but we no longer see the 20 to 30% rate of reversible dementias that we used to. But you still have to go through this differential diagnosis to see at least if you can remove the cumulative burden that medications or various illnesses might be imposing. A person's dementia, if a person is developing Alzheimer's disease, for example, they're going to have less cognitive reserve, and they're going to be very sensitive to medications or metabolic derangements or low thyroid or low B12 or folate. Those abnormalities may not be the cause of their dementia, but it may be further impacting their function. So we certainly have to still be alert. Routine labs and imaging is recommended for new cases. I think that an anatomic CT scan is the clinical practice guideline for most causes of old age dementia. An MRI gives you more detailed information. If you really want to pin down a diagnosis of Alzheimer's disease, it's a little more helpful in that regard. A person would be diagnosed with Alzheimer's disease with some confidence if the dementia has an insidious onset, if it's worsened over time, and it began with memory problems, and there's no evidence of other neurologic disease. I want to go to this table, and I don't know if you can see this, but this is Alzheimer's disease, vascular dementia, dementia with Lewy bodies, frontal temporal dementia, normal pressure hydrocephalus, major depression, and delirium. And I especially want to look at Alzheimer's disease and frontal temporal dementia. This tends to occur in older people, although certainly it can happen in younger people. This tends to happen, frontal temporal dementia, in younger people, people in their 50s and 60s, occasionally 40s, rarely beyond 70, quite rare. Poor recent recall is a hallmark of Alzheimer's disease, memory tends not to be as severely impacted in frontotemporal dementia, but executive function is. They have concrete thinking and disfluent speech. They do very poorly on measures of verbal fluency. Attention tends to be pretty normal or only mildly impaired. These people tend to have attention deficit disorder type symptoms. Both of them have generally normal neurologic exams early on. Both may have apathy and anxiety, but people with frontotemporal dementia tend to be a little more disinhibited or have psychotic symptoms early on. It's important to remember frontotemporal dementia in earlier, when you're seeing people in midlife who are developing cognitive problems. Dementia with Lewy body tends to be a disease of older adults. Their memory is not so bad, but they have very slow retrieval, slow movement as well, and very poor attention. They're sort of chronically delirious. They have visual hallucinations commonly, and a sleep disorder called REM behavior, where they tend to thrash around during dreams, sometimes even kicking and punching. All right. Once, I'm not going to get into drug treatment of different types of dementia. Dr. Campbell will be talking about treating psychiatric symptoms later on. But I just want to close by saying a word about counseling people with dementia. I like to be optimistic. Although the data for dietary interventions, lifestyle interventions, positive neuroplastic adaptation in people with MCI and dementia, the data to support the value of lifestyle changes is still weak, and the person with dementia may not respond as well as healthy older adults to exercise and dietary interventions and or cognitive practices. I think it's hopeful. I think it's important to instill hope and optimism that dietary changes, exercise, and cognitive challenge can at least prolong a person's function. Again, people with dementia may not respond as well to this, but it's important to counsel people about meditation, relaxation, adequate sleep, exercise, stress reduction, and mindful practices that engage the frontal system to improve cognition, so that when you set something down, you're actually thinking about setting it down. You're much more likely to remember where you put it if you take a moment with the scissors and think about where you're putting it. Promoting diet, healthy vegetarian and plant-based and fruit-rich diets, exercise and cognitive interventions. Again, not likely to help memory significantly once dementia is there, but it provides general health benefits which might slow the rate of decline. And at the very least, it improves morale and hopefulness. What do families want? They want a diagnosis, they want a prognosis, they want to know what the future is, they want referrals to community resources, home safety discussions, especially about driving. The patients don't want this discussion, but the family does. Referral to support groups, and the Alzheimer's Association also should be part of our conversation. And I have a listing of resources and references in my presentation, and with that, I'll end. Are you applauding because I didn't topple over? Is that what you're doing? Good.
And then we'll go on break, and I'll have to bring you back here to reconvene in this room at 10 o'clock. Are there any questions? One question, Brad?
Well, once a person has dementia, their responses to depression screening questions may not be as accurate just because they can't remember how they felt yesterday or the day before. Or yeah. You heard me say once they have depression. Yeah, no. Once they have at least a moderate degree of dementia. I might have said depression during one of my early experiences, but I meant once they have dementia past a certain point, then the questions should certainly incorporate family members and clinical observation of depressive symptoms. Yeah.
I'd like to introduce Dr. Roger Renfrew. Roger is an internist and geriatrician with more than 3 decades of experience as a clinician, physician leader, and community health advocate in rural Maine. As a geriatrician, he has served as medical director at 3 nursing homes. Dr. Renfrew served as medical director at Reddington Fairview from 1990 to 1993, and again from 1998 to 2010. He is the past chair of the Maine Medical Assessment Foundation and has served on numerous other boards. He is also a founding member of the board of directors of the Daniel Hanley Center for Health Leadership and the founding president of the Dirigo, Maine Geriatric Society, which, if anybody wants to join, by the way, we have some membership forms. Roger is also retiring from clinical practice at the end of June, and in August will assume a role as facilitator of clinical geriatrics at Maine General Health in Augusta. Dr. Renfrew, thank you.
Thank you. A couple of things that I just wanted to start off with is, for those of you who were at the meeting over the past couple of days, I heard a couple of times people talking about it isn't rocket science. And I was thinking about that a little bit, and rockets are very complicated things, getting people to the moon is, but human beings are very complicated. And so much of the work that we do does require a lot of complexity, and we'll touch on that a little bit, but I'm not sure that I like that comment that it's not rocket science, implying that it's simple. So my first proviso is I don't have any conflicts of interest. My second proviso is that there's a great deal of experience in caring for older adults in this room, and we can learn from each other. So I'll touch a little bit on Maine organizations for health professionals that are pertinent to geriatrics care. There's a Maine chapter of AMDA, the American Medical Directors Association, which looks at for medical directors in nursing homes, and that their journal actually is publishing some really interesting work on dementia and geriatric care that goes broader than the world that they work in. The Maine Gerontological Society, which sponsored the meeting over the past 2 days, which is really brings together a broad range of disciplines taking care of older patients, and then our newly formed Dirigo Geriatric Society, which really focuses more on clinical issues, but again is highly cognizant of the interaction and teams that are involved and the interprofessional work that has to be done. And these 2 latter organizations are very closely entwined in terms of leadership and trying to make sure that we are coordinating our work to take advantage and the benefit of two different organizations with very shared goals. I'd be curious to know who we have in the audience in terms of folks who are working with memory impairment. So the first group I would ask for are the primary care specialists. Now you notice that I'm not using PCP because there's all these fights about is it physician or provider, but it also enforces the point that the work of in primary care is highly specialized work in terms of the coordination of a holistic approach to the patient's care. And so how many people would describe themselves as primary care specialists here in the room? Great. How many are other community-based providers out seeing and working with older adults in the community? Yeah, yeah, good. How many work in long-term care or other facilities? Okay, that's the majority here, or the, how many students? Great. And how many in other disciplines? Great, thank you. So the goals are to talk about a structured team approach to geriatric care in a primary care office. We're going to try to keep it simple. We're going to talk about teams. We're going to talk about structure. And we're going to talk about quality improvement projects. Quality improvement is really sort of an amplifying the patient encounter through looking at what you're doing, and it's a constant interaction. So who's going to provide dementia care? There are 7,000 boarded geriatricians in the United States. That number probably, that's from 2004, and that number has been going down, not going up. There are about 12,000 neurologists. There are 2,500 geriatric psychiatrists, and there are 222,000 primary care specialists. And that number is challenging because many of them are now doing hospitalist work and not in the outpatient world or emergency room work. But the primary care specialists provide about 80% of chronic care for older Americans. One of the challenges, I think, in the primary care office is, are we going to deal with this like we do cancer, which is generally we make a diagnosis and refer, or are we going to deal with it like we deal with congestive heart failure, which is we diagnose it, we manage it, we may get some referral help on complicated patients. And I would argue, and will articulate through this, that there are parts of this work that really can only be done by a primary care specialist. Fundamental concept of geriatric care is function. And I learned this when I was first preparing myself to be a geriatrician. And I mean, what's the difference between what I do as an internist and what do I do as a geriatrician? And it really is, although diagnosis and management of chronic medical problems are important, it is really about maintaining people's function. And what I usually say to my audience is, if there's only one thing you take out of this meeting, if you remember that, I'm happy. So the Medicare Current Beneficiary Survey indicates functional status is more important predictor of death and functional decline than our specific clinical conditions. Gotta go back to that last slide. So the challenge in a primary care office is that you have multiple chronic illnesses, you have geriatric syndromes, you have social issues to deal with, and all of those are important in maintaining the patient's function. So let's talk about chronic disease management in the elderly. There are multiple medical conditions that patients see or come in with. They have multiple quality indicators. And the problem there is that there's little research on the metrics for quality indicators in vulnerable elderly or in people with multiple comorbidities. They usually focus on a specific disease. And generally, when you're designing the studies, you want clean study participants, and so you really try to strip it down to people with the one disease. The chronic diseases have significant functional impacts, and if you look at this issue about function being the predictor of further functional decline and morbidity and chronic diseases, the way I think about that is that age plus the multiple chronic illnesses contribute to your functional decline, but ultimately it's the functional decline that is the measure on how those are impacting our patients and indicator of their risk. Chronic disease management, one of the problems with multiple chronic illnesses is that they are sometimes undertreated and they're sometimes overtreated. Overtreatment being in the basis of either lack of good data on our elderly patients or overtreatment in terms of actually causing adverse events that are impairing function in our patients, and our target is function. So the American Geriatric Society at their May meeting in 2012 rolled out this initiative, the shorthand being 3+, but it's based on the fact that for people over 65, more than half of them have 3 chronic illnesses or chronic conditions. And almost all have existing guidelines, which again, with a single disease focus. So the initiative there is really to develop some guiding principles for the management of the patient or the older adult with comorbid conditions. And I attended a couple of sessions at this session this year, and you can really see people are working through these approaches and how they can be applied practically in the office setting. But the reality is even more complex, so it's 3+ equals 6+. And what happened was that in November of 2012, there was an article published in the Journal of the American Geriatric Society, and you know, the VA has this tremendous database, and so they can mine it, and as part of this 3+ initiative, they decided to look at patients who had 3 or more chronic illnesses and kind of what are the common triplets. So, and that, you know, it would be the usual stuff you might expect. So they have hypertension, they have diabetes, they have congestive heart failure, they have ischemic heart disease, they have COPD, they have osteoarthritis. So how do these clump together and what triplets are commonly seen? Sort of buried in that report was that in the patients with the 15 most common triplets, the mean number of conditions was 7 to 8.5, 9. And this was, to me, an incredible moment because I'm looking at it and I'm saying, okay, finally these academicians understand what's happening in my office on a day-to-day basis. So it was I really love this, this study. So beyond the chronic illnesses, we have geriatric syndromes. So geriatric syndromes are common syndromes in older persons. They're often multifactorial. They impair function. And because they impair function, they increase caregiver stress and increase the risk of institutionalization. They're undertreated, underrecognized. The other piece of that is that they often travel in tandem. So one of our little rules of thumb in our office is if we have an older person who is having falls, we're going to start looking for dementia. So geriatric syndromes, most of you are probably familiar with these, but memory impairment, and we tend to think, when we think about memory impairment, we tend to think about Alzheimer's disease, but Cliff was pointing out the multiple different things that can do that, some of which are not dementia, and so, or situations where drugs or other underlying chronic conditions make it worse. So the functional part of memory impairment can still be multifactorial. Falls and gait impairment are always multifactorial. Urinary incontinence, delirium, sleep problems, polypharmacy, elder mistreatment, and frailty are the big ones. So here's an office visit, 20 minutes, got 3 to 6 chronic problems, geriatric syndromes, social issues, right? That's the problem. So how are we going to solve that? So I believe that, and you could probably get a hint from my bio because of my interests in various administrative and other interests, that I would love structure. And I have, yes, the other day they were talking about our first speaker, Peter Whitehouse, was talking about left brain and right brain. I'm almost purely left brain, so but a structured team approach is an important component. So team is a big job, and as you will see, one of the things that my right brain has observed is that what we do in the office is does not even begin to touch what is needed. So the team we need extends well beyond the clinician's office. Only a small amount of the care of a memory-impaired older adult occurs in the office, and the office does not play the most important role in the individual's care. I don't remember if I put this slide in here, but let's see if we've got it now. One of the questions I would just pose to the audience is, what percentage of a person's time, we'll take an older person who might come into my office 8 times a year, what percentage of their life is spent in my office? It's like 0.1%. So this is a cartoon that I've been using and morphing over time on team in geriatrics. And so you have the office team, the informal support system, and then community resources. And when I started out with this being sort of physician-centric, that office team was in the center, and it was a bit bigger. And as I've evolved with this conversation, it's gotten smaller and moved over to the side. Still important, I hope, but again, just emphasizing this point that other resources and other support are more important. This is a cartoon of our office-based team. So this is the group that is directly around me. So medical records is involved in chart preparation and maintaining reminders. My secretary actually plays an incredibly large role because she's on the phone with people, organizing appointments, etc., and really does have an opportunity to observe in a way that I don't, and actually the more clinical part of the team doesn't have the chance to. Our medical assistant obviously has observations of the patient and also implements the mini-cog, and I'll talk about that a bit further as we get into this more. My evaluation in terms of dementia usually is very brief initially, and setting up a visit with my physician assistant. I provide diagnosis and management, and I put leadership there, but leadership in a team actually moves everywhere, and in the conversations that we have, it's a very flat leadership. Physician assistant doing template-based visits for geriatric syndromes and participating in diagnosis and management. That's an ongoing conversation as we deal with patients with memory impairment. So again, just another cartoon, but you can see that in the center is the care of the patient and quality improvement. That's the team that I use, and I'll come back and talk about how that is implemented and functions. But I do want to point out that you can do this work as a single provider. The American Journal of Family Practice just had an article on this a couple of months ago with basically articulating using multiple visits or weaving pieces into other visits using a reminder system and a flow sheet. Or Another format is simply the cancer model, which is recognize it and then refer to someone else to manage this problem. So structure is key to implementation of standardization. If you don't have a structure, if you don't have some measures, you never know how you're doing. I first learned this in the Indian Health Service. I was working on the Pine Ridge Reservation from 1975 to 1977. We're all young. We all know we're doing great work. And we decided to take a look at how we were doing in terms of tetanus immunizations in the emergency room, and it was appalling. So if you don't measure, you don't know. And the other point is, at this point in time, there are no geriatric-specific CMS indicators, but we do have a set of indicators called ACOVE, or Assessing Care of the Vulnerable Elderly. So this is a series of indicators designed for vulnerable elderly patients. And if you're of a certain age, are you geriatric? And the answer is no. It's really about functional decline. So there is work to identify a subset of people who are vulnerable, and to some extent we all know them, but this allows us to quantitate that a bit. And it's really, we're not way out at the point of frailty, but really sort of trying to sort out those people who come into our office regularly and at a higher risk. They have, I think now, 390 different indicators. Most of them things that we're familiar with, such as management of congestive heart failure or ischemic heart disease. But there are 17 specific indicators for dementia. And we'll talk about those further, but these are indicators that were developed by a process through UCLA Geriatrics, the RAND Corporation, and the American Geriatric Society. And if you just go to the RAND website, you can find literature references, and you can also find specific tools at UCLA. But again, if you just Google ACOVE, you'll find stuff. Cliff has already referenced the comprehensive roadmap, and this is part of the state plan and is another resource. So in our practice, we use a checklist, and that is on the left side of your packet. Looks like this, and this is it's a work in progress, and but we really try to address screening, diagnosis, management, and then follow-up. So screening. Should we screen? We'll take a quick poll. How many people here think that we should routinely screen people for memory problems in a clinician's office? Okie doke. How many think we should not? There are a lot of abstainers in this room. They win. So I won't pop that question on you. So why screen? Well, as Cliff referenced, it's underdiagnosed. Memory problems are underdiagnosed, and about 30 to 50% of people with memory impairment are not diagnosed. Case finding only picks up 20% of cases. That's where we are sort of, stumbling upon it. And there's variability. So we did a very simple QI using what we could pull out of our EMR, and we took everybody over 75. So we took each provider's population of patients over 75 and looked to see which ones had a diagnosis of memory impairment, and there was a tenfold difference in recognition. And there, the 63% are my patients. They're a little bit more complicated, so it's not a totally equal comparison, but it just gives you that range or a sense of how much variability there can be. And every time we look at something that has not been measured in medicine, we find this. So this is not, I was going to say rocket science, but This is not surprising. So ACO for dementia says if a vulnerable elderly is new to a practice or inpatient service, then there should be a documented assessment of cognitive ability and functional status. So a couple of points in this, or several points. One, they're not talking about every older person. They're talking about vulnerable elderly, a subpopulation. Two, they're coming down on the side of screening. The U.S. Preventive Services Task Force says there is insufficient evidence for routinely screening for memory impairment. So there's a gap there, and there are good reasons for that gap. The evidence base in terms of improved outcomes is weak. I'll speak a little bit to my impressions on that a little further in the talk. But then the third point is, and again, this gets back to what Cliff was talking about, is that we're assessing cognitive ability plus function. So, how do we screen? Well, we do case finding. I mean, that's sort of ongoing. And so if the patient has concern or expresses concern, or their caregiver expresses concern, then that starts us down a diagnostic pathway. Anyone on my office team, I've already spoken to my secretary's role and her ability to see things that the rest of us don't. And I live in a tiny community. You know, one of the things that I tell newly hired physicians is that you know, you really need to be careful what you say about your patients because they're related to somebody you work with. And that also plays out for us in terms of there are people in the community that we're watching each other, we're observing each other, and so people will come forward, either family members or neighbors or sometimes people who are on the staff, and they'll catch me in the hall and, is so-and-so your patient? And da-da-da. So that's case finding. And then we do screen. So we do screen formally with the annual wellness visit, and then I don't do and we do not use the annual wellness visit on a yearly basis in all of our patients. So we screen everybody over 75. And again, this came out of this QI showing the differences, and so we've embedded that, hardwired that into our practice. And we screen anybody with falls. We use the mini-cog, and basically the medical assistant does that. In the roadmap, there are also two questions which are asking about memory and organization. We ask those two questions. We use, let me see, we use a somewhat different scoring system than Cliff was referring to. And when you, again, Google the mini-cog, there are a number of different ways to score this. But we use a 5-point score, 0 to 3 for recall. So they've got 3 words. And I will tell you, the Alzheimer's Association on their website has alternate words to use. This becomes very important because as you're screening routinely, then they come in and they go, apple, table, penny, doc, you know. So you have to mix those words up. And then they get either 0 or 2 for the clock drawing. So the numbers have to be in correct order, and the hands have to be correct. And I've actually changed from this slide. 4 to 5 is normal, so that gives them 1 miss of a word. 0 to 2 being abnormal, so if they miss the clock drawing, it's abnormal, and if they or if they miss all 3, then they are abnormal. And then 3, I put question mark. Basically, what I'm struggling to do here in the practice is to make the mini-cog as sensitive as possible. So if they miss a couple of words, I'm probably going to want to investigate a little bit further. It's not for diagnostic purposes. And clearly, if they have trouble with that clock drawing, I'm going to want to move forward. So, you know, I'm sacrificing some specificity in terms of diagnosis to have something that's very sensitive up front to then start me moving down the path to figure out what's going on. So again, that's just the second bullet there is, again, research needs to be tight. That's why what you see in terms of the papers that are presented can be quite a bit tighter than what we do in clinical medicine. And so I like to think of clinical medicine as curiosity about the patient in front of you. Then for functional evaluation, we use two. And I think that's going to end with my departure. I've been using the VES 13, which is Vulnerable Elderly Survey 13, simply because that is attached to the RAND Corporation's work on the ACOV indicators for defining vulnerable elderly. But as our primary just kind of screening level, the instrumental ADLs, they're going to go well before the ADLs are going. And again, a sensitive tool. I will say that we have a flow sheet, and now that we've been doing this for a number of years, it's amazingly powerful to be looking at, you know, you've done a mini cog and their score has been 5, 5, and their IADLs have been 8, and then all of a sudden you see a drop in both and you're going, oh, something's changing here. It can be really, really helpful. So probably most of you know these, but again, and Cliff referenced them. The VES 13 is based on age, self-rated health, and functional assessment. It's a combination of ADLs and IADLs, and there's no use of disease burden with the VES 13. So it depends on that functional impairment being the final common pathway. And again, I suspect the use of this will drop in my practice with my departure. So I do want to stop and just kind of talk briefly about the reasons and what I've learned about formal screening within our practice. Number one is we are detecting patients with screening that we could have detected with case finding, but you know, it just doesn't sort of register with you. And so I think that that has been powerful. The other thing is that when you're using a sensitive testing for bringing in people, then you're finding people earlier in the course of a process. So we're finding a lot of people with mild cognitive impairment. And this has interestingly become very important in terms of legal wrangling in families. And so over a couple of years, I've been involved in a couple of cases that went to court. And the ability to have diagnosed this, found this when it is a mild cognitive impairment state, and that I, in evaluating them, can feel comfortable that at that point in time, they have capacity for decision making, and encouraging them to do what they should have done a decade ago and get their house in order has been very powerful. I've never had to go in court because it doesn't get that far. So I think that to me has been, those 2 points have probably been the most important, clinically important pieces in screening. So diagnosis, again, here's ACOV saying if a vulnerable elderly screens positive for dementia, then a physician should document an objective cognitive evaluation that tests 2 or more cognitive declines. Now this gets into some interesting arguments, the then a physician, because one of the things that happened with the ACOV indicators at UCLA was that they, in their academic geriatrics clinic, recognized they were really doing a lousy job on the ACO indicators that they had come up with. And so they hired a nurse practitioner to be responsible for making sure that those things were done. I use a physician assistant. So the terminology is a little old-fashioned. Then always have to emphasize, and again, Cliff made this point, but you cannot emphasize it too much because we certainly see people who've been diagnosed on the basis of some sort of a test with dementia, but it isn't dementia without new significant functional impairment due to that cognitive impairment. On the VES 13, the most common cause of significant functional impairment actually turns out to be degenerative joint disease. So diagnostic tools, we love the MOCA also. We use the mini mental status examination partly because there's so much literature with it, and especially when I was starting out, I really wanted that connection. We do both, actually, and it is interesting to see the comparison and the different performance structure of those two tests. It's not in the public domain. You have to negotiate. It took me close to 6 months. I mean, you can buy this stuff, but then there's this, you get this little card, cannot be scanned. I'm going, I'm working on an electronic record. What am I going to do with it? You know? And it took me 4 months of negotiating to get them to agree, okay, you can put it in a confidential file in your electronic record. And then the AD8 is a tool that you can get from UpToDate. I think the Alzheimer's Association also has it on their website, which is for an informant interview, a structured informant interview. Diagnosis, again, Cliff has addressed this. We talk about the 3 Ds, delirium, dementia, depression. Sorting those two out is sort of the first level. Are you really dealing with dementia? I've added the 2 Ps, which is polypharmacy, because in dealing with geriatric patients, one of my rules of thumb for medical students and residents is if something is going wrong, what am I doing? And usually that's the drugs. So the first level is just, you know, are we actually dealing with dementia? Are we dealing with mild cognitive impairment? Are they normal? Do they have a normal mental status exam, but concerns? And this is the area oftentimes where I find I need neuropsychiatric testing, because you're just kind of teasing that out, sometimes teasing out if there's underlying depression. Those are the ones I tend to use that the most. And then the second level is basically getting to that differential diagnosis that Cliff explored in more detail. So in our practice, if the screen or history raises concerns, then we move to a PA templated visit. So on this form, that's specific visit number 1, which is listed as number 2. And so the focus is on a history, which is templated in the electronic record, a mental status examination, a physical exam, a medication review, and then decisions about and proceeding with further workup. So again, you can see this is now happening. You know, the mini-cog is abnormal. I'm dealing with the multiple chronic illnesses, and honestly, you know, I might take less than a minute to talk about this in an office visit, and then I'm sending that person to my physician assistant for this very specific evaluation. And what we found out, I mean, QI can be, okay, we're measuring stuff and is it statistically significant or something like that, but just keep it simple. You know, I meet with my physician assistant every 2 weeks just for conversations on the broader picture of what we're doing rather than cases. And it was really clear we weren't meeting all of the elements. So we went to a 2-visit approach, and oftentimes we're now at a 3-visit approach, just because there's so much on this to get it done. And we developed the flow sheet, again, you have this problem of where does the work go, who's going to do the work, and so medical records is actually entering the information onto the flow sheet. We don't do that. Management, I think Cliff in other talks has pointed out that about 65% of patients with dementia receive cognitive enhancing medications. And this remains controversial. The 2 Ps, polypharmacy. And again, this is one of those places where I really feel strongly that the primary care specialist is the only person who can do this job, because you've got to balance this against the functional impact of the other chronic illnesses. And your cardiologist wants them on drugs that are making them fall or potentially impairing their CNS. We do, I don't know, how many people here are familiar with the Beers list? Great, okay. And again, the anticholinergic medications, Cliff's reference to the fact that you don't see as much reversible stuff is because we use these things all the time. Benadryl used to be the gentle sleep aid. And then management is much more than medication. Again, if you take a look at the checklist, you'll see the things we're dealing with. Medical illnesses are very, very important here. And again, you want to manage those to maximize function. And again, oftentimes having to think about how they impact the patient's cognitive function. Patient and caregiver resources and connection to community resources. The legal issues I've addressed, driving, both of us addressed, and cringe a little bit when we think about it. The management team, the work in the office shared, again, between us, and key things are communication, and my PA is in the office right next to me, and obviously we can communicate through the both the flow sheet and the EMR. So one of the things that we found very quickly was that we weren't routinely connecting with community resources, and so we just connected with our area agency on aging. And we have a packet of information, and we strongly encourage people to connect with them. As most of you know, the area agencies on aging have 2 roles. One is to provide services, and 2, to be a single entry point, to refer to other resources in the community and to be aware of those communities. So they put together a pamphlet for us. We stick in a booklet on Alzheimer's disease, but again, it really references the importance of that caregiver support. I had one patient I saw who was a patient of one of my colleagues, and that colleague had articulated concern about our comfort level with dealing with early cognitive impairment and making that diagnosis. And this woman came in with an acute illness, so I ended up seeing her. Her caregiver was with her, and her caregiver started. So there were 2 things that happened in that were interesting. One is I was told right off that the patient had difficulty with hearing, so my trick with that is to sit close, almost like with this microphone, and to make sure the tone of my voice is low. But then also within that, there was a recognition and a recognition from the caregiver, a concern from the caregiver about memory impairment. And the thing that was interesting was, of course, this woman with the hearing impairment speaks fairly loudly. So when I was sitting in my office working on my note, I heard, "That's the first doctor I've ever been able to hear." But then the second thing that happened was I just gave the caregiver this packet, and she was almost in tears, knowing that there were resources and help and that this was recognized. So I think that that emphasis on and connectivity is really a powerful thing. The follow-up is we're still struggling with our standardization on this, but really, reevaluating the mental status and how frequently. But again, the flow sheet is tremendously helpful in terms of that, both in terms of the monitoring the IADLs and monitoring the mental status, looking for behaviors. And again, you're treating, even though that other person in the room may not be your patient, they're your patient. And it's really critical. And again, the flow sheet can be really helpful. So 80% of chronic care will continue to be provided in primary care offices. A structured team approach can help to make sure that you're doing that well. And then refer when you need help. Geriatricians, neurologists, geriatric psychiatrists. Limited resources here in Maine, but they're there. I do want to take a couple minutes to talk about, Cliff alluded to this grant called the MedCaps grant with the Office of Aging and Disability Services, and the idea is to make Maine dementia capable. Has a broad reach, but there is a focus on physician practices. And Cliff and I are the primary people working on this part of it. And we will be working on building a CME session which gets much more hands-on than this 1-hour talk. This CME session will also be available on the Lunder-Dineen website so that people can access it. And then we're interested in recruiting offices that are interested in doing QI around this issue. We will be working with quality counts to try to put together approved QI processes for maintenance of certification for both the American Board of Family Practice and the American Board of Internal Medicine, so you can get points for your recertification. Those, although we will talk about the pretty much the full 17 ACOV indicators. Those will focus on screening, diagnosis, and referral to community resources, because that's a big weakness. And my email is there if people are interested. Even though I'm switching jobs, although I will not look at my professional email for the month of July, I will have access to it afterwards, even though I've moved. So I think we're at this point. So thoughts, concerns, issues? Yes?
Can we have access to your flow sheet as we're developing our own offices?
Yeah, I can. Yes. Short answer is yes. Email that to me. I haven't prepared that in an easily transportable form, but I can. And again, it, like everything else, is a work in progress. Yeah. Yeah. Any other questions, or for those who yeah. Yeah.
On the average, how many times do you bring a patient back into the office to complete the whole process?
Yeah, I think that it's somewhere between 2 and 3 visits to do it, and that's my physician assistant can schedule them for as much as an hour's time. But there's some of the stuff is pretty straightforward, and some of it is a little more complicated in the discussions. I will say, there is some concern, and I think we heard that a little bit from Peter in terms of labeling issues. It is handy to have mild cognitive impairment as a diagnostic entity, and but I look at it a little bit like when I was in medical school, Elizabeth Kubler-Ross published her book on death and dying, and just how in this world in which we did not share the idea of fatal illnesses with patients, you had patients over here knowing damn well something is going on that's serious, and you have families and everybody else over here knowing the same and nobody sharing that. And it is unhealthy. It is not good for the patient. And generally, what I see when we make a diagnosis of Alzheimer's is relief on both parties' part because they know something is wrong. Sometimes, if it's later in the course of the illness, of course, the patient with dementia may not recognize it. But Cliff and I probably see a different spectrum of the disease generally in terms of what you see in primary care and what you see in a referral situation. So, yes.
What U.S. Women's Health Task Force, you said that they would recommend screening anybody over a certain age.
They don't recommend screening, period.
Just screening vulnerable.
Yeah, they do not basically, and they're very evidence-based, and they feel that there is not sufficient literature evidence to justify screening for memory impairment. And I must admit, in that world of the annual wellness visit, when I have my healthy 65-year-olds, and it's a little, it feels sort of useless, but again, I've articulated the benefits that I feel out of it. And yes.
I think one of the things that helps you understand screening is that when you screen a general population, you have to know what the starting place of that individual is, and the tests that figure out what a family and a person anticipates they should perform at a test and then what they actually perform on a test have been more accurate types of instruments.
Yeah.
But they haven't really figured out one that really gets that information in a testable form.
Right.
So
And
the baseline you were recommending, it sets a bar so that subsequent tests become a valuable screening at that point.
Yeah. No, I think that, and that's again another place where one of the other powers of being in primary care is the patient over time too. And again, but that diagnosis, new functional decline, is part of the diagnosis. And yeah, great. Thank you. Other comments or questions? Okay, terrific. Oh, I have one other thing. I have a poem. I have one other thing. I'm sorry, I forgot this. This is the most important part of this. So I actually do have right brain, and I love to collect poetry about aging, and so this is a poem. This is a poet that I just discovered, Mary Jo Balistreri, who is. She was a concert musician, developed breast cancer, and then decided to get off the road, and is now focuses on her poetry, and she just has this wonderful light touch with language. So, and this poem is specific to Alzheimer's disease. It's called Stage 1. Ease of years, as comforting as the salty breath of the sea, we walk together, two old friends. Underwater, an alligator bends the swaying marsh grass and cattails and lurches at a flutter of feathers. My friend speaks in hushed tones, the word Alzheimer's, and my husband barely escape from her mouth. She begins to cry. We lean into each other, tears lapping against the shore we share. We walk and talk among the twists and turns of the mangroves. Note the bronze leaves that sailed beyond our reach on the brackish water. As she trails her fingers along a vine of bougainvillea, she turns and says, I had forgotten their crepe paper touch. Loses herself in a heron's blue wings and the slate blue trajectory of flight. We reach the edge of the ocean, stand and watch the sun's slow descent to the sea. In the umber of its flickering votive, silence hovers, vague and implacable. Thank you.
Roger, thank you. Roger always has such poignant, lovely poems to conclude a session. We're very, very pleased to have our next speaker with us today. And he is Dr. Matthew Janicki, who is a research associate professor of human development at the Institute of Disability and Human Development at the University of Illinois at Chicago. He also serves as director for the technical assistance for the Rehabilitation Research and Training Center in Aging with Developmental Disabilities at the university. Formerly, he was Director for Aging and Special Populations for the New York State Office of Mental Retardation and Developmental Disabilities in Albany. And Dr. Janicki was a Joseph P. Kennedy Jr. Foundation's Public Policy Leadership Fellow, spending a sabbatical year at the National Institute on Aging and the United States Senate. He is also the author and editor of numerous books and articles in the area of aging, dementia, public policy, and rehabilitation with regard to people with intellectual and developmental disabilities, and has lectured and provided training in aging and intellectual disabilities around the world. Dr. Janicki is a fellow of the American Psychological Association and the Gerontological Society of America, and served as chair of the United States International Council on Mental Retardation and Developmental Disabilities, and as the founding chair of the Aging Special Interest Research Group for ICID. Currently, he serves as the executive officer of the International Association for the Scientific Study of Intellectual Disabilities, and is the editor-in-chief of ICID, Journal of Policy and Practice in Intellectual Disability. Dr. Janicki's research interests include epidemiology and demographics, Alzheimer's disease and people with intellectual disabilities, community dementia support services, and aging correlates in people with various etiologies of intellectual disability and associated conditions. Dr. Janicki.
Thank you very much for that wonderful introduction. Now that it's on TypeScript, if I can see it, appreciate it. I'm going to cover a number of areas in the next hour I have to kind of give you a flavor of the area that I'm most involved with these days, and that's intellectual disabilities and dementia. I also, by the way, serve as the co-chair of the National Task Group on intellectual disabilities and dementia practices, which has been organized to kind of track through what the U.S. government is doing with the National Alzheimer's Plan. And I'll talk a little bit about that. It's going to give you a flavor of what that means. The big picture notion, and I kind of start with the big picture because I used to be responsible for planning for the New York State agency that I worked for. So we're going to start with the big picture and you work down to the tangibles. The WHO report, you probably may have seen this if you haven't. It's basically is a very interesting report that came out a couple of years ago, which basically outlined dementia as a public policy issue, a public health priority. And it basically puts the world on notice that dementia is, among other things like obesity and other conditions that WHO is involved in, is something that needs to be attended to by various countries. And I've just thrown up some numbers up here. You can read those. The critical thing is that the report, and this is maybe a little harder to read, does cover and reference intellectual disabilities, which we're very pleased to see. And it also had recognized our National Task Group as an American organization that's working on trying to correlate practices and services for people with intellectual disabilities and dementia, along with what's happening for the general population who are affected by dementia. So that's sort of the big picture. So we step down from that and we move into other things. This is the 2014 update to the National Plan to Address Alzheimer's Disease, which has been published recently by the government, came out in April. The plan basically stems from the National Alzheimer's Project Act, which was created by Congress in 2010 and then put into place in 2011. What that plan calls for, in very simple language, is that the government must have a plan to address Alzheimer's disease through the period 2012 to 2025. So as you can see, there's quite a long window of opportunity and obviously work to be done, both by the private sector and the public sector. The plan is also updated annually, which basically introduces things that the government has reported that it's done, and is also introducing things that it needs to be doing as they gain more information and we move on. The plan covers a number of areas, including what research is trying to do in terms of defining what the cause of Alzheimer's disease is and how to treat it, which at this point we don't have all that information. It talks about services for people. It talks about assistance to caregivers. It talks about public education. It talks about a variety of things. And it talks also about special populations. And the three special populations that are introduced into the plan include minority populations, early onset of dementia, and people with intellectual disabilities. So sort of that's the framework. These are some little quick bits of informational bits that were in the 2014 plan. For the first time, a very significant mention of intellectual disabilities as part of the agenda of the federal government and the associated partners of that effort. And I won't go into all the details, but I'll do it if I have some time at the end. So you can kind of get a sense of the development. And we've been very active over the last 3 or 4 years in kind of nudging the whole process along, which I'm very pleased that we're getting a lot of good response from the feds. Okay, so we're getting into the issue of why we're concerned about this area. And I think one of the things is, I don't know if you've heard it from the speakers beforehand, but certainly the thing you do know is that the demographics basically are portending a large older population. And then Maine, obviously, is one of the states that has one of the largest older populations in the country. It also deals with the issue that Alzheimer's disease currently affects a significant number of Americans. At this point, about over 5 million, and projected 9 million over by 2050, which is a number of years ago, but years to go. And also that there's a number of people that are affected after age 60, which is increasingly growing as people grow older. And the number of individuals who have intellectual disabilities are also affected because there are on some of the segments of the intellectual disability population, particularly Down syndrome, are high at risk, and this is where you get the early dementia issues. Just to illustrate what we mean in terms of what population we're looking at, this kind of gives you a sense of the trichotomy, as it were, of the older population and the urgency of needs. And the outside ring basically are the folks that are well elderly, like myself, I suppose, who are in that age grouping and who consider ourselves relatively healthy at this point, functional. And then we have folks in the middle area which have some marginal needs basically that are starting to age in some ways and demand some supports and services. And then in the core, and this is where we usually focus a lot of our attention on, we have the people that are sort of the most needy individuals because of age and disability and associated impairments. And this is where we get into the area of dementia. So it's kind of give you the framework. It's not everybody that's old has the problems that we're looking at, but it's usually a small core. But it's a very important core and a very needy core, and one that needs a lot of attention financially. So what are some of the needs that we need to take a look at? One is we need for best practice models for community-based housing, which so people have to deal with. We need needs for supportive services when people are living in their family homes. We need some practice guidelines for medical and health care, which we're beginning to evolve. We need adequate screening, assessment, and diagnostic resources. And I agree totally with what was said before in terms of the screening issues. When we're talking about screening, we're really talking about early detection and not necessarily screening the population. And we need more information on the population and the effects of dementia in terms of its needs for long-term care. So those are some of the framework needs that kind of deal with the whole issue of identifying the population, dealing with the planning, the public policy issues, and things like that. So let's shift over a little bit more to the clinical aspects. And these are some of the questions that oftentimes are raised in the area when we address audiences and we talk to people and we interact with agencies and organizations in terms of the whole issue of dementia and intellectual disabilities. And a lot of individuals, and I suspect that this is not a group that is unknown to this definition, but a lot of people in the general population just do not understand what dementia is. So that has to be defined. And they oftentimes confuse the issue of cognitive disability with intellectual disability, so that has to be defined. So that, the differences between the two. There has to be some information about how it impacts people with intellectual disabilities, and is the impact different, the same? I'll try to deal with that this morning. Will all people with ID be affected in old age? Who will and why? And how can we respond? What are some of the services and responses that we can develop to accommodate people who are developing this condition or these various conditions, and how do we best serve them, and who can help us doing that? So let's first identify this issue of difference between intellectual disability and dementia. And if you're not familiar with intellectual disability, basically we're talking about a lifelong disability that either involves prior to birth, at birth, or during the developmental period, which is usually toward the end of the teens when brain maturation occurs. And it usually talks about undeveloped or underdeveloped mental and intellectual skills and capacities. And remediation is a key feature in there where people can overcome some of these by training, by education. by habilitation, by assistance. So we're talking about a condition that essentially affects a person's individual function. Now, as you probably are aware, dementia is basically a widespread loss of mental intellectual skills and abilities. Excuse me. And it usually occurs, reflecting in a number of things like losses of memory, language skills, orientation, ADLs, and changes in evident personality and global functioning. The big difference between intellectual disability and dementia is even though there are some equivalent intellectual capacities and deficiencies and dysfunctions that occur in the older age, one group of individuals, the people with intellectual disability, are basically still functioning well, and they're growing and developing skills, where people with dementia are losing the skills and they're declining in their capacities and abilities. So you have sort of a crossing of effect there. So the big difference is basically is that you've got skills and you're losing them versus you haven't had all the skills and you're trying to gain them over a lifespan. So that's the difference. And when we're talking about some of the dementia warning signs, the familiar signs that you've probably seen before, I listed them here on this chart. But the big thing is that there's a difference in the character and the presentation oftentimes of some of the signs. For example, if getting lost and misdirected is a sign that someone who's functional and is showing as a sign of dementia in the general population, that may or may not be a key indicator for people with intellectual disabilities because they may never have had good orientation skills over their lifetime. So you have to kind of temper some of that in terms of your assessment. So the warning signs may be signals for an assessment or signals of a decline, or they may be simply a reflection of the intellectual disability. So we have to discriminate between those two. So what are some of the differences between the general population and folks with intellectual disabilities in this whole area of dementia? Early onset, for example, is usually prevalent. I mean, people with Down syndrome. Down syndrome folks make up about 10% of the population of people who have intellectual disabilities in older age, over 40. So it's a significant group of individuals, and people with Down syndrome also are a significant risk factor, pose a significant risk factor for people who develop Alzheimer's disease. And also head injury. Those are the two areas in intellectual disabilities that's a more signal in terms of having declined. So early onset is evident usually in those two conditions, but it is not necessarily evident in other people who have other etiologies, whether they're socially based, environmentally based, or genetically based. So there's that main difference there. What about symptom presentation? I think the main thing here is that we see some early personality losses, mostly in folks with Down syndrome, as a signal for some changes as they begin to develop some of the signs and symptoms of dementia, whereas memory loss is usually seen in the general population and other folks with ID. So there's some of those differences in terms of symptoms. What about assessment? You heard earlier in the presentation about some of the mechanisms that are used for assessing individuals in the general population and some of the standard measures and even some of the innovative measures that are self-developed here that are applicable to the general population. You can take a test like the MMSC and apply it to a general population, and you can usually get a filtering effect from the test that will tell you who's affected generally and who's not affected in terms of the decline in performance. When you're dealing with folks with intellectual disabilities, you can't use those same general measures because you don't know where the people are starting out from. The assumption with the general population is you have a baseline or base informational point. People generally know who the president is, they know what day it is, they know where they are. They can travel from point A to point B. When you're dealing with folks with intellectual disabilities, you have a wide range of intellectual abilities, and so you don't know what the base is. So you have to use measures that are more significantly picking up the strengths and weaknesses of an individual, and then periodically remeasure against that individual to see if they're showing changes over time. So the periodic reassessment of an individual are usually the telling measures that are usable with folks with intellectual disabilities, where general purpose instrumentation that's normed against the general population is used with the general population. So that's the difference in assessment. In terms of services, most of the services are the same. People need assistance with caregiving at home. People need housing. People need supports. People need day services. The main difference, I think, in some regard is that usually there's an organized system of care in most states across the country that provide lifetime supports for individuals who have intellectual disabilities who are part of the system. And as they age, and if they develop dementia, those supports kick in, specializing for that particular condition. Where in the general population, people just live on their own, basically, and have their own lives. And if they need specialized services, they have to then seek out those specialized services as opposed to something automatically kind of tracking and kicking in for them. So I think the condition with intellectual disabilities and the services are much more richer in availability. And again, it depends on states and how much they're funding those services, but generally there's something there. So those are some of the differences. Now let's take a look at 3 areas that are sort of significant for us to think about in terms of the area of dementia and intellectual disability. Onset, progression, and duration. The issue of onset, I've talked a little bit about the onset, the early dementia onset, folks with Down syndrome, but the issue of onset is speculative anyway, because we really don't know with great precision when onset occurs. What we know is that we can begin to observe the behavioral changes that someone has and the decline factors that signal us or kind of stimulate us to think that something's happening to an individual. It could be, not being able to drive well, not balancing your checkbook. People don't balance checkbook these days. The banks do that for you when you go on account. But dealing with your financial accounts and paying your bills, just taking care of your life in general, these kinds of things are indicators that if there's changes in that, indicators that something's happening. And usually, the more complex the skill in the event, and if there's a decline there, that's the one that's usually affected first. So what we're looking for in terms of onset is when things are beginning to change. Now we know that there are some studies now and research being done in terms of biomarkers. And the studies in those areas are telling us basically that the biological, neurological onset sometimes predates by behavior onset by about 20 years. So I hope that one of the things that's going to happen out of this national plan in the United States is that the researchers are going to tell us basically that we can pinpoint more accurately, physiologically and neurologically, through chemistry in the brain and things like that, when we're beginning to suspect that something is actually there and verified earlier on. So interventions come into play. One of the things that we're finding from the research literature and clinical practice is that once the disease is progressing, it's more difficult to change it. If you can intervene early, when the early signs may be there but not significantly yet impairing individual, you can produce some change and deflect some of the changes that are going on. So that's an important consideration. Now, the other point in terms of onset is the difference in the age of onset. And the chart here shows you the difference between Down syndrome and other folks with intellectual disabilities. And the yellow bars are the Down syndrome onset ages, different age groupings, and the green bars are the ones representing the others. The average age of onset for people with Down syndrome is usually in the early 50s, about 52, 53. That's the average age, sometimes in the 40s, sometimes in the 60s. But the average age for Down syndrome is usually in the early 50s. The average age of onset, which is again this behavioral recognition something's going on, for other folks with ID, usually in the late 60s, 70s, 70s, like the general population. So that's the Down syndrome folks have the early onset feature, other folks don't. What this tells us also is that we need to be surveillant, and we need to take a look at the folks that we do have. If those of you who work in this field, in the disability field, if you have folks that you're working with who have Down syndrome, people in their late 40s, early 50s should be target groups for early detection mechanisms, and we'll talk a little about that later on. The earlier you can pick something like this up, the more you can do in advance to help the person adapt and deal with some of the issues. So that's the issue of onset. The other issue has to do with progression, and this is a kind of a graphic illustration of the progression, the cognitive progression of deterioration due to Alzheimer's disease. This is an artist who painted himself basically, and the left chart, the left painting there in 1967 shows him before he had any symptoms and signs of Alzheimer's disease. And I guess 1996 through 2000 shows him the progressive deterioration of his ability to reflect himself through a portrait. And that's basically showing the changes in the brain, the ability to perform, brain and hand motion and things like that, interpretive information that comes out of portraying you as an artist. So I'm just trying to give you a flavor of the progression impact and also the linear progression. It's a downward slope with Alzheimer's disease. It's fairly, once you know you're on that course, you're going to be moving through it. And as you do move through the course, you actually go through certain stages. The other feature is there's some differences in what type of dementia you do have, and this is just illustrating the stepwise progression of vascular dementia, which is not so much linear, but more a step up. Basically, if you have a vascular accident, at some point you begin to lose some function, then you stabilize, and then if you have another one, you lose some more function. So The difference here is that if you know the type of dementia and the type of progression you're going to go through, you can anticipate what you may expect in behavioral change and what you may need to do with individuals who are affected. In terms of Alzheimer's, for example, and other conditions, you do have a staging process that occurs. And you know somewhat, I suppose, what the expectations are for some of the stages in the general population. But generally speaking, that the early mild stage, anywhere from 2 to 4 years once you recognize something's going on, mid-moderate 2 to 10 years, and then late severe 1 to 3 years. It's a little different with folks who have Down syndrome. You have a compressed staging. So you may go through these stages in 2, 3, 4, 5 years. This is an illustration of a gentleman that we had in a study that a colleague of mine had going. And you can see here that from age 57 through almost 60, he declined quite quickly to the point where he was basically dysfunctional, and he died soon after this last photograph was taken. So there's a compressed staging with adults with Down syndrome. So not only do you have early onset, but you also have a quicker progression through the disease, which again affects your care, treatment, planning, and housing situations, and all the accoutrements that go along with trying to prepare someone and deal with someone who's affected by Alzheimer's disease. So that's an issue around staging. The other thing in terms of progression pattern and duration is the expected trajectories of progressive dysfunction. And this reflects people in the general population in a study that was done of 6 people over 14 years in terms of their trajectories. You can see each one having a different pattern in terms of how many years it took for them from being diagnosed to dying, and also the decline factors in terms of how progressive that decline was or how slow the decline went. The same is true in intellectual disabilities. Once you get into folks, there's not much difference in terms of these patterns of decline. So, but that gives you a little flavor. And what it tells you basically is there's no unitary pattern except the fact that you eventually will decline. So how many years you're affected really is difficult these days to be able to judge for an individual unless there are other confounding factors or coincident conditions that may affect the health of the individual and speed up the affected process. So that's one of the features to think about in terms of the progression pattern duration, in terms of service provision, service planning, in terms of how many years you have to house someone, for example, who's affected, what you do, how you set up those services for housing, and what are the specialized services for each stage. So this is one of the features that we think about in the intellectual disabilities arena. So the other factors that kind of are introduced here, as I mentioned, stage-related changes. If you know what the stages are, then you can begin to project what kind of staff and what kind of housing may be needed based on various stages. And the end stage usually is a significant decline in dysfunction of the person individually. So they can't really function on their own. They have to have personal care, nursing care. So that's one of the features in terms of this endpoint. The remaining life years, you really don't have a good sense until you know progressively how much the person's affected in each stage and how fast that decline may occur. There are some aggressive forms of Alzheimer's that affect people with Down syndrome that once you decide that the person does have Alzheimer's disease, they may go through all the stages within 18 months or 24 months and then have died from it. That's a quick progression, and there's aggressive forms in the general population, but primarily in Down syndrome as well. But and most people with Down syndrome don't have aggressive forms. They have a compressed progression, which is about 7 or maybe 9 years, as opposed to a longer progression of about maybe 20 years, 15, 20 years in the general population, other folks with ID. So those are things to consider. And the types of dementia will also influence these trajectories. And the other thing that influences is health status, the coincident conditions. If someone comes into old age already with having some significant physical and neurological impairments, that may compromise them if they've had lifelong seizures, if they've had other features that may affect their lifespan. And by the way, speaking of seizures, seizures are one of the markers of Alzheimer's or dementia presence in people with Down syndrome. If you have late onset seizures, not early onset, but late onset, in other words, if they're in their 50s and they start having seizures for the first time, that's a telling fact that something's happening neurologically in the brain. And it's usually tied very closely to the identification of Alzheimer's as an issue. So just quickly kind of give you a summarization of some of the findings that are particular to folks who have intellectual disabilities and the whole dementia issue. The rate of occurrence, what we're finding basically is the prevalence rate among people with ID is about the same as it is in the general population, with the exception of people with Down syndrome and a couple other things, a couple other areas. So if you think of it, about 5 or 6% of people over 60 affected in the general population by Alzheimer's or the dementias, that's true for ID as well. With people with Down syndrome, that rate goes up to about 60% over 60, and significant about 40 to 50% over 50. So it's a high-risk category in terms of having demonstrated Alzheimer's disease. Now, it used to be that people thought that everybody with Down syndrome would die from Alzheimer's, but we're finding now that people will live on and die from other reasons before Alzheimer's becomes diagnosed in them. And but even though, oftentimes upon autopsy, you'll see the neuropathological changes, the plaques and tangles, evident in the brain of someone with Down syndrome, but never the behavioral dementia presentation. So we have some interesting features there the researchers are looking at. The dementia type, usually people with Down syndrome have Alzheimer's disease when they're affected by dementia. In the general population, there's a variety of dementias that will affect people. Same is true with folks with other types of intellectual disabilities. The onset and duration, the average age of onset for Down syndrome, as I mentioned before, is usually in the early 50s, 60s, late 60s, early 70s for other folks. The behavioral changes, there's more evident personality changes at early stage. In people with Down syndrome, there's more initial memory loss in other types of individuals with intellectuals like there is in the general population. The neurological signs, usually late onset seizures you see, and the data are kind of all over the place. As you can see, 12 to 84% doesn't really, there's not a high level of precision, but if you do see late onset seizures, it does tell you that something's happening. And usually it's in Down syndrome. And the prognosis, the aggressive forms of AD can lead to death in under 2 years, but most of the time it's 2 to 7 years for people with Down syndrome, and other types of longer duration for folks with other types of intellectual disabilities. So those are some of the significant findings from the research literature. What's important to know here, then? If you're trying to identify some of these key issues in terms of whether dementia is present or not, it's good to know about the difference between normal aging changes and pathological aging changes. So sometimes benign aging may be, something we'll think of someone's having difficulty with memory because they're getting older, but it could be just benign aging. It's not an issue of dementia. We need to know about early signs of functional change associated with dementia. We need to know about the types of dementia and their main characteristics. That would be the behavioral functional changes in the duration. That's useful for staff to know and agencies that are working with folks with ID who are older. We need to know when it's best to refer for assessment and to whom. We need to know what options exist for early dementia-related supports, and we need to know what options exist or need to be put in place for long-term dementia-capable supports as well. This is kind of an elaborate little schema that I put together just to quickly show you the differences in things that move along. The top circles that are popping down now are basically the identification process. You start on the left here with suspicions are raised or routine screening detects changes. You have a request for an assessment. An assessment validates the suspicions and changes. There's usually a reassessment to indicate continued decline changes to validate the previous one. Then you have a diagnostic review. This is where you get into all the instrumentation, all the tests and things. And then you have a differential diagnosis. And the differential diagnosis basically is that it's either possible or probable dementia or it's not dementia. And if it's not, it could be something else that's affecting the function. It could be a thyroid condition. It could be depression, medication overload. It could be a number of factors that are creating the same kind of symptoms as dementia does. So, and then you have basically the program adaptations and services that you have to put in here. And you have the diminished function, stage-related concerns. These add up to change, sometimes changes at where a person lives or change in residence itself. And so this introduces things like dietary changes, hydration, nutrition, weight you have to think about, changes in the staff paired to dementia stages to have more expertise in dealing with someone who's functional versus dysfunctional, ambulatory versus non-ambulatory, adaptations of living environments, sounds, lighting, wayfinding safety issues, the adaptations to routines and activities, lower stimulation but engaging activities, and then specialized attention to the ADLs that come up, the activities of daily living, and then issues of health, mental health, incontinence, memory cues, and things like that. So these are all kinds of program adaptations that kick in once you begin to suspect and validate that there is a dementia issue involved. So again, that's a little complicated, but just kind of in one slide illustrates some of the process points. So getting into some of the issues related to ascertaining dementia, there was a good discussion made about screening earlier, and we've been using this word screen, but we also mean, what we mean by it is early detection mechanism. And it's usually on a person-by-person basis. It's not screening the whole population of folks with ID. You wouldn't go into a state like Maine or an organization that runs an agency, that runs a service in Maine and say, okay, we're going to do this test with everybody. Basically, you'd get the folks that you're suspicious about, and then you'd have apply some kind of what we call a screen, basically to say yes or no on some functions. And so you start with an administrative screen, and I'll talk about what the NTG DST is in a minute. One way to do that is capture visuals. And each of us now probably has some kind of a phone that does video recording. Used to have to set up cameras and mechanisms and do all the fancy stuff and very expensive. Now you can do it very inexpensively. You pull out your phone and you just record someone doing some standard things like walking back and forth, talking to you, doing some fine motor things, getting through some memory things. And you just log that into the record. You have a digital record. And then later on, maybe 6 months from now, a year from now, you do it again. And then maybe another year after that, if you're suspecting change, and you can begin to see if this person's beginning to have some expressive dysfunction. And that's a really inexpensive way of doing it. So you can see if that kind of screen provides hits or warning signs, or you can use a paper and pencil screen, which we'll talk about in a few minutes. You can also refer to clinical assessment afterwards. In other words, clinicians who are expert in doing this dementia recognition assessments. And they'll, especially if they're familiar with people with intellectual disabilities, so they know the difference between the presentation of intellectual disability versus the presentation of dementia. And that's a critical point, because if they're not familiar with that, they confound the two, and they won't be able to give you a good assessment. If the evidence points to dementia-like symptoms, then you want to refer to a full diagnostic evaluation with all the bells and whistles that go along with that. Okay, so some of the challenges to diagnosis and care in the ID field, and one is that individuals with ID may not be able to report signs and symptoms. I mean, most of us, if we're having some problems and see a physician or see a diagnostician, can tell them what their symptoms are. But when you're dealing with someone who may have low verbal skills or low understanding of what they're experiencing, they may not be able to report those signs and symptoms, so you have to kind of infer them, pick them up from other staff, other informants, things like that. The subtle changes may not be observed. And again, as you're dealing with mental functioning, you may or may not see them on the day, because you may have some of the good days, sometime of the bad day. Commonly used dementia assessment tools are not relevant to people with ID. We talked about that earlier. The difficulty of measuring change from previous level of function, again, if you don't use the same measures over time, you're not going to have apples. You're going to be comparing apples and oranges as opposed to apples and apples. The challenges with assessing change in adults with severe and profound ID. Now, if you're working with folks who have IQs that are below 20, 25, you're dealing with a factor that's very difficult sometimes to assess whether dementia is present or not. And there's some experts in the world, I say the world because there's not too many in each country, that may be able to discriminate that, but most people won't be able to. When you're dealing with conditions associated with ID may be mistaken for symptoms of dementia. Sometimes the person may function and behave in such a way you associate with dementia, but it's not dementia, it's just part of their personality and character. There's a thing called diagnostic overshadowing, basically, is that people will just describe to an individual something because that's the way the nature is of their category of disability. And oftentimes we find in our practices that someone who's referred to a clinic and has Down syndrome, the clinic will say, well, this person has Down syndrome, and so we're not going to go any further than that, so that's what we mean by that. Oftentimes aging parents and siblings, who are usually the informants, are less apt sometimes to give you good information because of their maybe distance or other things like that. And there's a dearth of research training sometimes to do differential diagnoses. So these are some of the issues that do come up. So if you're concerned about whether there is dementia, I think the kind of a tracking point is keeping track of the behavior. We'll talk a little bit about that, how to do that in a minute. Use some kind of digital recording device, as I mentioned, use a screen or early detection instrument, seek advice from the clinician, gather as much information as you can, speak with other program staff, speak with housemates, speak with family, review the record for previous status, history, mention of decline. These are all factors that would influence what you're trying to collect. So when we get into screening, we look at screening, assessment, diagnosis as sort of 3 steps in the process. And in the screening, we have some administrative screens, which we'll talk about. There's some clinical determinant, I guess you can call them screens in some way. They're more clinical assessment instruments. I mentioned them by letters here, if you're familiar with those in the ID field. If you're not, we have them on our website. I'll talk about that at the end. This dementia assessment scales that are more clinically oriented in terms of neuropsych, and then you have the diagnosis options, possible, probable, and definitive. So there's a need for an early detection screening tool, and the reason for that is because in the field there wasn't really a good way to document change that related to dementia. And when we in the NTG started our process a few years ago, we kept picking up this request for some kind of administrative score or scale that could be used to help identify folks who have problems, and that it could lead to the diagnosis of dementia. So, and this also comes up in terms of clinicians reporting individuals who have problems well in advance of significant signs of dementia, starting to pick it up in annual neuropsych exams and things like that. So why do screening? Well, screening tools help capture information about early changes in behavior and function. Caregivers can be good observers and reporters of relevant signs and symptoms of changes, and screening tools provide a common format for sharing information. And the other thing is that we've been talking with the feds about using the screens for the relevant ACA, the Affordable Care Act cognitive assessment as part of the annual process. And they've recommended, CMS has recommended a number of scales that could be usable in the general population. None of them are really usable with the ID population in general. And we've had some discussions with them about, making that note, making people aware that those scales are really not appropriate or usable, and including maybe some alternatives for people to use. So those discussions are ongoing. This is the instrument that the National Task Group commissioned, and it was developed through a working group, a national kind of consensus meeting group. And it's called the NTG Early Detection Screen for Dementia. And basically it's designed to be used at a very basic level by staff of organizations and agencies that serve people, as well as caregivers and family members who can fill out information about an individual. And we call it an administrative screen. There's no scoring that comes out of this. It's not going to give you an endpoint number. What basically it does is it collates and aggregates information about function and behavior and health that you can then sit down with someone who's a clinician and discuss what you think is happening, and they can get feedback to you. The scale is basically 6 pages, and the first page is some basic information, pages 2 and 3, information about function indicators and problem areas associated with dementia. The things that we asked or developed on the scale basically are points that are usually associated with dementia presentation. So we asked questions that are relevant to that so that you don't waste your time people filling out the form. And then page 5 are the coincident conditions, other health conditions that may influence function and behavior. If someone's having some difficulties with a thyroid, for example, you may want to look into that before you make the jump to dementia, because that's showing up on the scale. And then the medications and comments are on this page 6. So basically this is used to pick up ADL skills, behavior, function, memory, self-reported problems. The person can reflect on some of the problems they're experiencing. We'll pick up things like changes in residence, changes in staffing, changes in other life conditions. So you can kind of pick up all these different things that you think should be discussed, and you have it on one piece of paper. Well, actually, literally 3 pieces of paper front and back, that you can have a discussion with a clinician, so that person then has more information when they see the individual. And you can highlight the things with a matching marker, whatever it is, and say, these are the areas I really want to discuss with you. So that's what that screen is all about. So then when you get from assessment, when you get from screening, you get to assessment, where you get the much more formalized oral psych exam or geriatric assessment exam of the individual, and the clinician will look for specific things to follow up on that screening information. So that gets you into the whole diagnostics area and other things. So those are the things that are done by the people who are doing that process. Okay, so some of the barriers to effective assessment, the absence of specialized training among clinicians, and it's difficult sometimes to find clinicians. I mean, in our system, we can kind of point to people here and there across the country that are the real experts in this area, and it's difficult to find folks that are more knowledgeable than that. There's usually a poor knowledge of assessment protocols to assess dementia in the ID population. There's a dearth of assessment services, too, in terms of who do you refer to get accurate diagnosis. There's a lack of familiarity with identifying dementia in adults with ID among primary care medical practitioners. In the first instance, when you refer someone to a primary care physician, they may not really pick that up because of the nature of the disability, and confusion of symptoms and misdiagnosis. And some of the reversible, treatable causes of dementia in folks with ID, adverse drug reactions, depression, metabolic changes, nutritional deficiencies, head injuries, these are all factors that might contribute to that. Okay, so I want to get into something about program options and kind of give you a flavor of where that's going. So I kind of broke this down into foundation support and care management. And what's the optimal dementia care in folks with ID? I think the foundation, basically, the settings need to be dementia-friendly and dementia-capable. And from a model perspective, philosophical perspective, we want to do basically is avoid institutionalization or reinstitutionalization. Many older people had spent many years in public institutions or private institutions, and now they're out. And the last thing people want to see them do is go back into institutions because of this issue. So, and we also don't want to see people who have never been in institutions end up institutionalized because of the dementia issues. So that's really the thing here, the underlying feature. And so you want to avoid that. The structure of it is that we're looking at individualized personal care. Basically, it's a person-centered model. We want the settings to be comfortable, offering long-term commitment to care with family or a small number of co-residents, capable staff, educated caregivers, adapted environment, and protection from abuse, harm, and neglect, the safety features that we would like to see for anyone, I guess. The key issue here is that with dementia, it basically lessens an individual's ability to be left alone. They cannot live on their own, and thus eventual living without supervision is not an option. So when you have folks with ID, the field oftentimes will emphasize independence and independent living, and over the course of their lifespan, they are given more and more options to basically be independent, and oftentimes may live on their own or live with a housemate. When dementia starts to occur, that becomes much more trying, and it can compromise that ability to do that because the person begins to have judgment issues. They may leave a pan on the stove, as the kind of traditional example is they may walk out in the middle of winter and not well dressed and freeze. They may get hit by traffic, whatever. So these are all issues in terms of personal care and personal independence that have to be compromised when you get dementia. Some of the supports that are needed certainly are when the person's living with someone, help for carers and the person, advanced planning for alternate care, diagnostic intervention assistance. One of the important areas is support groups for both the carers and family and staff, looking at some kind of dementia-capable community housing, preferably group homes, so the small kind of comfortable care settings, respite for carers, health care, and social supports. These are kind of a gamut of things. The focus is on three areas: basic environmental supports, in other words, compensating for the cognitive losses and disorientation. So you have the environment being that kind of supportive environment, so it's designed on the way to accommodate some of these changes. You have primary care practices such as supporting safety and mobility, offering protection against injury and disease, and the program applications, minimizing behavior that disrupts the equilibrium of the home and poses a danger to self or others, and helping maintain dignity and skills. It's a balance between what the person is experiencing and what you need to do is to maintain sort of the quietness of the home, as it were. The program adaptations in the contextual way is rethinking how data, life, and regular activities are approached. Lessening stimulation while promoting involvement and challenge, the modifications in communication methods, and supporting residual skills. The rethinking how daily life and regular activities is approached is a key feature in the developmental disabilities field. Staff are trained early on when they were hired by agencies to be in tune with what we call the developmental model, which is basically enabling people to become more and more independent over a lifespan, gain skills, learn things, benefit from life and life's challenges and activities. And with dementia, those issues and mechanisms become compromised because you have to offer some more structure, less choice making, more controls, as it were, because of the nature of the memory loss of the features. And so staff have to sometimes, who work in dementia programs, have to be reoriented in terms of that model of care from one that deals with development and progressive learning and independence to one that deals with sustenance and maintenance and things like that. So that's a challenge oftentimes in the field of ID. When we're looking at coordinating dementia-related supports and services, we're looking at the models, going from housing to health and medical, family supports, clinical teams. The housing should be adapted to dementia services and care. The clinical teams, interesting notion, what we're proposing, or we should be proposing anyway, is that oftentimes organizations in the community will join forces and have 2 or 3 specialists who are trained more in the area of intellectual disabilities and dementia, and they become sort of the clinicians, the consultants to others in their environment, in their area. The family supports, dealing with home adaptations, respite, support groups, counseling. Families still provide the bulk work of housing for people who have lifelong disabilities. And as they age themselves, parents are challenged again with something that's happening to their son or daughter that they didn't expect to happen. They were looking at old age being supported by their son or daughter in some ways, and now they're having to reintroduce greater supports for their son or daughter because of the lessening skills. So this supports the families is a very critical issue. And then the surveillance of symptoms, review of coincident conditions, and follow-along in terms of health and medical issues is a feature that's important. So what are some of the factors that aggravate care decision-making? The change of care focus, going from making gains to that of maintaining function, dealing with eventual loss and decline. The implications for this basically are the staff trained in developmental growth techniques have to be reoriented, as I mentioned before, to think in terms of maintaining capabilities. We have to think about care situation planning that has to consider progressive decline and greater inadequacies. That, the person's not going to have the same skill set that they had before as they decline. So you have to adapt to that and think about how you're going to organize your services and supports around that from a day-to-day basis. And then care environments have to offer structure and comfort, and the familiarity, which again is important to provide that structure. So just summarizing some of the things that affect some of this is one, is that we find a higher prevalence of neuropathology indicative of Alzheimer's disease in older adults with Down syndrome. We know that Alzheimer's type is the most prevalent dementia in folks with Down syndrome. We know the studies show the average age of onset is in the 50s for people with Down syndrome, late 60s for others. Dementia presents with variable rates of decline. We know the duration may range anywhere from 1 to 2 years to 10 to 20 years, depending on type and confounding factors. We know that living alone, self-care is not a viable possibility when progressing loss of function. If living at home, long-term care may not always be possible because of the caregiver burden, the home inadequacies. The person may live on a second floor, or the bedroom may be on a second floor, and that may be an issue. If living in group quarters, staff may not be prepared to provide long-term care, and communities may not always have viable in-community care resources. So these are all sort of challenges in this area. When we look at the types of care options that are usually available in the general population, you have institutional care basically as a term for long-term care facilities, nursing homes, old age homes, dementia, special care units, memory centers, and things like that. Then you have family care basically, which is the most prevalent one in the population. This is where people live with their own families or other relatives or surrogate relatives and things like that, or siblings. And then you have, in the ID field, you have neighborhood group homes, and neighborhood group homes also as a growing option in many countries in terms of Alzheimer's care. It's a model that's starting to be adopted, for example, in Sweden, Japan, a number of other countries. So you have these kinds of models and these options. The issues of each are indicated here. You have the value of family care home. You have care at home enables continuity in your setting, and people know each other, they know the setting. They can usually accommodate the changes that they're experiencing because they know they've been in that home for a lifetime. There's a family commitment to supporting aging and problems associated with decline. There's a value that's enabled if family gets support from continued home care. There's respite, home modifications, aids to help primary caregiving, and financial assistance usually for the family, and usually provide safety and security. So those are the features that are on the plus side of continuing to provide family home supports. And then you have the value of small group home care. And I'm talking about, not talking about like 20 people. I'm talking about, 5, 6, 7, 8, 9, 10, if that. In lieu of care at home, next best option for comforted families. In fact, one of the studies we did, we asked families who were caring at home, if you weren't around, what's the next best option for you? And they usually referred to a small group home that they maybe had a hand in developing or being involved in the board of. Many countries are adapting to small group livings as alternative institutional care. They're intuitively and empirically viable, provide personalized care and community living, connection to familiar settings. There's a significant research based on structuring quality settings. And in the IT field, they're readily available because they transition. People sometimes go into those settings from home to get some skills, and then they move on their own. So the homes are usually in the community already, run by the state or run by private agencies and things like that. So those are some critical points there. So this is a model that has emerged from some research that we've been doing at the university in terms of comparing two types of home-based dementia care, group home-based dementia care. One is what we call the aging-in-place model, which is basically a single home, and the person progresses through all stages of dementia in the home itself. And there's a commitment to provide care for that person in that home, because that's their home, just as if they had heart disease, they had cancer, they had something else. So this is just another feature of it. And so aging in place is one model. The next model is this in-place progression, where you may have the luxury of having multiple homes by an agency that may operate them. And so the people start off in one home at an early stage, and then as they progress, there may be some variations in the mid-stage in terms of specialization. And then as they progress even further, there may be 3 types of homes where you're dealing with early stage, kind of early mid-stage, or later mid-stage, and then late stage. So you can kind of specialize the homes in terms of the nature of the cares provided, maybe the design, maybe some adaptations, environmental adaptations and things like that, particularly around the end stage, late stage dementia, advanced dementia, where you're dealing with people who may be not ambulatory and need a lot of personal care, where these others are folks who are ambulatory and need differential rates of care depending on what they bring to it. So these models are starting to evolve across the country in terms of how agencies are dealing with this. The thing you have to take into is trajectory, because as you develop some of these homes and you have similarity among people as you enter the homes, over 4 or 5 years, the homes may change in character because of the nature of trajectories. So what are some of the constructs that we have to think about? One, we have to talk about fixed staffing, the familiarity, mutual comfort, person focus, unregimented care, personalized attention and schedules being at home, the familiar surroundings, they're easily navigable, fixed personal space, intimate public spaces, adaptive features, fixtures, lessening confusion, the small residence size, familiarity of others, friendship, home feel, high comfort level. And the care practices, they're really tailored to the individual, attention to needs, easy to pick up on change indicators and group problem solving. So these are some of the features that tend to reflect that. I just quickly wanted to, let's see what, 5 minutes, okay. Let me skip over this, because this was a model that we've been following. Actually, I'll just quickly go. This is what we call the Wichita Project. We've been following these 3 homes that were developed by an agency in Wichita as dementia care homes. They're all open at the same time about 3 years ago, and each of them have 5 people in them. And they are now progressing as we're studying them in terms of the changing character of each home. And we're finding that one home still has folks with early mid-stage. One of the homes has people in advanced stage, and one is in between. And it sort of evolved that way. And this is some of the, 2 years later, we're finding basically evidence of change in function, increasing health problems, or less wellness in the people compared to controls, which are not people affected by dementia. The residents in 2 of the homes showed the greatest impact of dementia over 2 years. A higher number of comorbidities among dementia residents compared to people who don't have dementia. Staff time spent on caregiving, much more than that for people who don't have dementia. And there's a trending toward individual home specialization. The model I showed you before, we had 3 homes. Each home's now beginning to identify as specialized. Even when someone died from one of the homes, they were replaced with someone who had very similar characteristics as the person that had who died. So some interesting evidence is coming out of that. These are just some publications that have come out around the world dealing with this issue. So in community care, what needs to be considered? I think one is where the person is in respect to dementia progression. Can he or she stay where they currently live? Should a specialty dementia care home be considered? If so, what's the most appropriate pairing? What are their wishes or the wishes of the family? What options exist in agencies or in the community? Are the current services geared up for long-term care? Is there a dementia-capable residence in the locality? Have direct support clinical staff knowledge of dementia and long-term dementia-related care? These are kinds of issues that need to be thought about. Very quickly, just kind of tell you about our national task force, because it has an effect on a lot of things that are happening. We're on the web. Our website's on the bottom here. You can get all these things. This is our seminal document that came out. My thinker's not working, because that came up as a quote from someone that we were interviewing who had the intellectual disability and talked about how his brain's changing. These were some of the things that we identified we had to do when we first began. We wanted to define best practices that could be used by agencies delivering supports and services. We wanted to identify a workable national first instance early detection screening instrument. We wanted to produce educational materials to use with families, people with ID, and providers of services, and further public policy with respect to dementia. And some of the activities that we've actually gone through, a lot of our publications are available. I've got some up front here you can take a look at, but you can get all these on the web. You can download everything we've got. So we've got a screening instrument out. We've got practice guidelines for both health practitioners and community service people. We do training workshops. We're in the process of developing a national curriculum for training staff who are employed by agencies, and we have linkages to various national federal organizations. Let me skip over the practice guide. This is our practice guideline document, basically for community care. It tells you everything you need to know from A to Z, based on a staging model. This is our practice guidelines for physicians who see people as part of the assessment process. Health advocacy guidelines we're now in the process of issuing for people who want to be advocates and advocating for health services for people. Standard curriculum, excuse me. This is our curriculum. It's beginning to evolve. We have 3 levels. Level 1 basically is for new hires in an agency. Level 2 for those people already employed. And level 3, people working directly with people who are affected by dementia and intellectual disabilities. And then these are some of the things that are coming out of the 2014 plan update, basically looking at actually convene a workshop to examine the special needs of people with Down syndrome. The NIH is going to do that. And then strengthen state aging, public health, and intellectual disability workforces. Educate family and service providers of persons with intellectual disabilities about changes that may indicate the onset of dementia. Enhance understanding of models of family support for people with intellectual disabilities at the age. Provide education about respite care for caregivers of people with Alzheimer's disease. And improve the dementia capability of long-term care services and support systems so they can better meet the needs of people with Alzheimer's disease and their caregivers, and enhance training to address the needs of individuals living in long-term care settings. These are all reflective somewhere along the way in the descriptions of that, and you see these long paragraphs about intellectual disabilities. So what are some of our efforts that are ongoing? One, improving understanding of dementia, alerting to risk and early signs, adapting living environments, helping with futures planning, aiding families who are carers, enhancing staff skills, quality checks of services, providing stage-related services, and getting federal government to invest resources. So those are where we're going. How we're going to measure our impact in 2025, we'll see. One is have lives been improved, which is really the critical thing, so better quality for people. Have agencies been able to deliver more appropriate and worthy services? Are families better off? Have we set a standard for how people with ID affected by dementia should be seen and treated? Has there been a shift in thinking and in actual program changes? And has there been more attention paid to ID issues within the Alzheimer's communities by researchers, advocates, public policy people, et cetera? And if you can't see from the back, that's our website up there. And if you just go into the website, you'll see everything you need to know that I've been talking about. It's all there. So that's what I have to say. How do we do? We're good. Yeah. Sorry. That's my New York training, speed talk. Try to get it all done in an hour. Go ahead.
In your housing,
Yeah.
have you ever had the person with Alzheimer's and the caregiver
Live together?
move
Live
into
together?
a facility?
Some organizations have thought about that. They've tried to develop sort of like a Alzheimer's units. The difficulty that we try to let people know about ahead of time is that you can do that, but then if the parent dies, the son or daughter is kind of left living in an Alzheimer's program who may not have Alzheimer's, right?
I'm talking about a spouse.
Oh, give me the question again, because I may have missed. How is the spouse related to this?
How is it possible?
No, what's the connection with the spouse?
You're referring to not just a non-family caregiver, but you're talking about the person's spouse. Yes, yes. In my
Yeah.
particular situation, I had to sell our house. I have really no place to go and live. Is there any place, has there been any models done where
Yeah.
the spouse has the Alzheimer's and you could go to
Oh, I see.
someplace and
Okay, so you're talking about a
actually-
spouse, not person with intellectual disability.
Yeah, and be able
Yeah.
to help care for.
Yeah, assisted living provides that. A lot of organizations have assisted living units, apartments, that will accept both spouses, both husband and wife to the unit and provide with the care that they need for the person who's affected. Now, the problem is, what are you going to do afterwards, or how long that lasts, and how much it costs. Those are all features. I don't think any of those are done on a Medicaid model. They're usually done on a private pay model. But they do exist.
We just need to find it.
Yeah, I know. That's the difficulty. But you can keep, ask around. There's a question in the back. Well, okay, in the intellectual disabilities field, is the state agencies will have by federal and state mandate the obligation to provide lifetime care sometimes for people who have long-term disabilities. And as part of that, they do provide supports, financial supports for housing. Sometimes they'll pay for apartments, sometimes they'll pay for co-living situations, and they'll also underwrite the cost of group homes for agencies that want to run them. States vary in terms of how much money they put into it and how big a network it is. When I was working for New York, we had an extremely large network of group homes because we basically took a lot of people, over 20,000 plus, out of institutions and replaced them in the community. And group homes were the major focus because that was quick and dirty, as it were. And then those folks then progressed into the community for other reasons. But again, it's on the state. The money comes basically, if it's a Medicaid program, it comes from the federal government, co-share with the state. If it's a state-funded program, it comes from state appropriations. We have a sign-up section. If you go to the website, on the right-hand side, you'll see a menu for everything that we have. And one of the things is membership. And if you want to become part of the National Task Group, you're welcome to. It's not a closed society. It's an open society. And we constantly get new members signing up. And what the members do basically is you have time, you volunteer. If you don't have time, you just kind of lurk and you listen and you gain from what we're doing. And we oftentimes will send you information about what's happening. We'll ask for your advice on things and counsel and things like that. So if you want to become a member of the National Task Group, you just go to that website and you can sign up and you'll be part of it.
Thank you. All right. I would like to introduce Dr. Mary Sano. And Dr. Sano is Professor of Psychiatry and the Director of the Alzheimer's Disease Research Center at Mount Sinai School of Medicine. Dr. Sinai is also the Director of Research and Development at the Bronx Veterans Administration Hospital, and currently she is the Director of a national multi-center study known as CLASP, Cholesterol Lowering in Alzheimer's Disease to Slow Progression. Dr. Sano is a neuropsychologist by training and has been involved in designing and conducting clinical trials for Alzheimer's disease, Parkinson's disease, and mild cognitive impairment of aging. In 1989, she received the Florence and Herbert Irving Clinical Research Career Award to develop methodologies for the assessment of therapeutic agents in Alzheimer's disease, and has directed the first ADCS multi-center trial of vitamin E and seglaline treatments, which delayed the clinical progression of Alzheimer's disease, and in 1998 received the Veris Award for this study. In the study, minority participation was more than double that of any other clinical trial for this disease. Her research interests are in clinical trial design and the impact of pharmacological treatments on the functional abilities of individuals with cognitive impairment. And at present, Dr. Sano is the director of a new clinical study to determine if home-based assessments can be used to access treatments for the prevention of cognitive loss and dementia. She's also developed tools to assess the economic impact of subtle cognitive changes in elderly subjects. Other areas of interest include the role of depression in cognitive impairment and dementia. We welcome Dr. Mary Sano.
Well, thank you so much for the invitation. It's always a pleasure to come to Maine. It's such a beautiful state, and I am so impressed by the commitment of the workers here today. I want to get started. My job is to sort of update you on the research that's going on in Alzheimer's disease, show you how much of our research has been integrated into clinical care and diagnosis, and perhaps to hold out some hope for the next stages. I just want to provide you with this list of my disclosures. They're also available online. Today's topics, I'm going to talk a little bit about our success and how far we've come in diagnosis and treatment, talk a little bit about lifestyles and comorbidities. I'm also going to spend a lot of time talking about research and taking the next step. You had a very important introduction to that at our panel at lunchtime, and hopefully I'll get you to see how really important this topic is. This is a slide I don't need to show to anyone in this room, but it's a good stepping off point. It's the fact that Alzheimer's disease is one of the most feared diseases. In fact, this increase in the worry and concern about Alzheimer's disease continues to go up over most other diseases that the elderly face. Despite that, and our awareness, particularly at the end stages of what seems like a fatal condition, it really is important to realize we've made progress. We have improved confidence in the diagnosis by clinical evaluations, by using imaging and biomarkers. We now know that the risk factor of apolipoprotein E4 may have relevance even before a person has symptoms. We have approved treatments for Alzheimer's disease, and though the effect is very modest, it is very robust and exists in most trials. And most recently, we re-demonstrated from that 1997 study the fact that vitamin E does seem to have a benefit in patients with Alzheimer's disease, including in the mildest cases. So this is just a quick reminder that even before Alzheimer's disease, we have cognitive decline that really is what is the aspect of the disease that worries most of us. And in this slide, what I'm showing you is that those individuals who actually perform more poorly on cognitive testing have a very rapid transition from normal cognition to dementia. And in fact, the rate is about 15% per year. In about 3 years, a person who has poor memory performance, about half of those individuals will have a diagnosis of dementia within 3 years. And in fact, this graphic is to show you that while most of us focus on the amyloid accumulation, because that is where we're now trying to get an answer, there are many things that contribute to this cognitive decline. Some of them are environmental, some of them are a range of other metabolic conditions that also have an impact, and sorting this out may be an important aspect to getting benefit in the disease. So I may have shown you this slide last year. This agent has now been available for more than a year. This is florbetapir. It is what brings us the new confidence of a diagnosis. In a person who has dementia, we can now image amyloid in their brain. It is available, though not necessary, when we have a well-diagnosed clinical case. But in those unusual cases when we're not sure of what it is, we have this new extra tool that can tell us that, in fact, there is amyloid at the level that we would expect it for a person who has the disease. And this has FDA approval. Other biomarkers are being examined, and what I'm showing you here is a list of biomarkers that are collected from the cerebral spinal fluid through lumbar puncture. There is, again, some growing evidence in the presence of symptomatology. This information can be very helpful. What we do see is that the biomarkers give 100% accuracy for the diagnosis of Alzheimer's disease. However, the accuracy of the biomarker to assure that the disease that is causing the cognitive impairment is Alzheimer's disease is somewhat lower in the presence of mild cognitive impairment. Some of those individuals may have a positive biomarker, but may be in a more fluctuating state. And a factor that we've identified here, and I'll be talking a lot more about, is the fact that about 35% of elderly normals have a diagnosis, have a biological marker, both with CSF and with imaging, that suggests they have full-blown Alzheimer's disease, at least at the level of pathology, when they have no symptomatology. We'll talk about what that means in just a minute. I mentioned apolipoprotein E. In 1995, when we became familiar with this agent, we would say that it should only be used in a workup with an individual who had dementia symptomatology. We know that the presence of an E4 allele, just a reminder, we have two alleles. They can be 2, 3, or 4. If you have 1, 4, you have a threefold increase in the likelihood that your dementia is Alzheimer's disease and the likelihood that you will progress to Alzheimer's disease. If you have 2, it's more than tenfold. Now, in 2011, the new diagnostic criteria have suggested we might consider, in the presence of an individual who has mild symptoms but not a full-blown dementia, to include this as part of the diagnostic workup to tell us if we're going in the direction that might be Alzheimer's disease. The key importance here is how much energy do we put into worrying that we have another condition. And this can help an individual and the family and the physician have confidence about their diagnosis. Another aspect that I wanted to point out to you is while we do have treatments for dementia and Alzheimer's disease, there's often a controversy as to whether or not they're worthwhile. And this is a recently published study with a drug that's been available on the market for some time. It's galantamine. This drug was studied in a European clinical trial that is a registered study. The purpose of this study was to determine what the effect of the agent was on survival. There's been some concern that these agents may actually increase the risk of mortality. In fact, this randomized trial shows just the opposite. What you're looking at here is improved survival over a 2-year period in individuals who are taking galantamine. Equally important is that this is the graph of the mini-mental performance, and a cognitive benefit remains present over 2 years. You can see there's a continued separation. So the reason this is important is because we often say, is it really worth it? Every randomized trial of cholinesterase inhibitors at every stage of the disease has shown some benefit. And here, for example, is another piece of evidence that suggests this. What I'm showing you is in severe individuals from, I believe this is the New England Journal article. What you see is those individuals who have no medication actually have the greatest decline both in cognition and in activities of daily living. This is the increase in their need for assistance. And so improvement here with all of the current treatments. So again, this is to simply say that while we can often be nihilistic about whether or not these drugs work, every randomized clinical trial has demonstrated a benefit across disease severity. And here is the report that I mentioned to you earlier. This is a report looking at vitamin E and memantine to determine if there was a benefit in these mild individuals with Alzheimer's disease. And basically, once again, a benefit was observed in terms of a slowing of progression on functional outcomes, activities of daily living. Why is this any different than the 97 report? These individuals were all taking cholinesterase inhibitors, and this benefit was seen above and beyond cholinesterase inhibitors. In addition, there's been some concern that vitamin E might have a safety profile that would make us walk away from such a high dose, but in fact, the safety profile was quite excellent. There was a non-significant trend towards better survival in those who are taking vitamin E than those who are in those who are taking placebo or memantine. So this is evidence, I think, that our clinical trials work. This was done in a completely different population. They were done in veterans, all who have multiple comorbidities, randomized, placebo-controlled study. Now I want to talk a little bit about our concerns and hopes for prevention. And when we talk about prevention, one of the problems is we always hope that we can think about something that's less aggressive, something like physical activity or a supplement that's, quote, safer. And will that provide us with prevention? Because if you're healthy, you don't want to risk any adverse event that might come from a drug and also undo the benefit you're hoping to find. However, this report in 2010 from the National Institute of Health suggests that there's really very little evidence that any pharmaceutical, dietary supplement, cognitive or behavioral intervention really can prevent Alzheimer's disease. And I want to walk you through some of the data that it spoke to. The interest has been for a long time in whether or not we can modify lifestyle and if the modification of risk factors can have a benefit. And here you see a list of potential lifestyle modifications, diet, sedentary lifestyle, stress, head injury, diabetes. All of these things have an epidemiological connection, but very little clinical trial evidence of a cognitive benefit. It may be that there's an indirect path and it's not actually reducing Alzheimer's disease, but it's maximizing cognitive reserve and cognitive ability. And the other thing is that they may not be independent risk factors, because in fact it might be that the diseases themselves are increasing cognitive risk. And what you're doing is not changing the Alzheimer's likelihood, but just the cognitive deterioration from one of these other conditions. A report several years ago suggested that the modification of these 7 risks would reduce Alzheimer's disease by 50%. And what you see on the other side is some limitation of this. In fact, the modification of these risk factors is quite available, and the uptake is growing. And in fact, there has been some evidence of a slightly reduced incidence in Alzheimer's disease, not prevalence, but incidence. There's still incident cases, but that rate of incidence seems to be deteriorating. However, it will plateau as these risk factors all come under as good a control as we can have. And yet we know the disease still exists and we need to find better ways to think about it. I wanted to talk about some of the challenges, and one of the ways I like to illustrate this is with the information about the Mediterranean diet and dementia. All of you may have heard of the great papers that looked at the Mediterranean diet in individuals in an epidemiologic study, looking at their intake of foods and seeing which ones fell into the Mediterranean pyramid. Well, since that time, an actual randomized study began to look at the cardiovascular benefits of such a diet. And this data was published not long ago, and what it shows is that, in fact, there is some benefit with the Mediterranean diet in terms of cardiovascular risk, a reduction in the risk of MI and stroke, and a reduction in mortality. That's pretty impressive. It's a large and long study, but it's really rather impressive here and here. So in a small cohort from here, not so small, over 500 individuals, the study included a cognitive outcome to see, can we get a cognitive benefit? And in fact, there is a cognitive benefit, but it's really important to realize how small this benefit is. What you're looking at here is the mini-mental scores of individuals in the control condition, in the Mediterranean diet and nuts, and in the Mediterranean diet with high use of olive oil. And basically what we see is a benefit in these conditions. However, it is tiny. It's about a point. And in fact, it's important to remember that this is really very small benefit, though it is significant. 6 years, less than a point on the mini-mental in non-impaired individuals. It's a challenge to think about how long and how many it will take for us to determine what might have some little benefit. What about physical activity? This is a question that everybody is concerned about. There are several studies that have been summarized by the group at Cochrane, the collaboration out of Oxford, that has suggested that there does seem to be some benefit, in particular from aerobic activity. However, it's been very hard. No 2 studies seem to see a benefit in the same outcome measure. So this is a real challenge. This study demonstrates that in comparing individuals who actually had aerobic activity versus a stretching module, that over a year's period, both groups had cognitive benefit, but only one group had some actual increase in hippocampal volume. And this is a pretty sort of exciting idea, because hippocampal volume would suggest that it actually is having a biological effect in the area that we think is most related to memory. So it's an exciting possibility, but even this study has to face the reality that there are some groups for whom we're going to be able to observe this In larger, older, and more sedentary groups, it's been much more difficult to see this. The question or the answer might be that you have to start young to get this kind of a benefit. I always throw this slide in here because I think it's important to realize that separate from its cognitive benefit, the physical activity, particularly that seen in team sports, may actually have some benefit, perhaps by increasing socialization. This is a great picture from a South African women's soccer team who play. These women range from 50 to 85, so there's a chance yet. This slide I use to tell you about the challenges of looking at supplements as benefits in clinical trial. This is a study that looked at DHA, an omega-3 fatty acid, and showed in a single memory test in a randomized trial a benefit in individuals who took DHA. However, again, it's really important to realize that these were individuals who had low omega-3 in their diet. What's low? Less than 2 fish meals a week. For many New Englanders, I think routine diet may take you well above this level already, and you don't see the increase in omega-3s, nor do you see any additional benefit. And this is the very important study that was completed in 2008. People tend to forget about it, but it is really an important study in which ginkgo biloba was examined in a double-blind randomized trial of individuals over the age of 65. And as you can see, there's no separation of these two lines. Whoops, sorry. There's no separation of these two lines, meaning that in fact the presence of this agent did not change the risk of dementia. I think it's really important to think about how to evaluate these studies as well. What I find so important is they took healthy individuals, they made a projection about the rate of conversion to dementia, and all of these projections were met. What was not met was the efficacy of the drug. So we know it's a good study that follows all of the behaviors we expected to see, but in fact, that we just were not able to observe this benefit. And the other comment I wanted to make is this study started with over 3,000 individuals and studied them for over 7 years. Hopefully you're getting a feel for how much effort it takes to do these prevention trials. I don't always throw this material in, but I think it's important to realize, particularly when we're not necessarily talking about what causes Alzheimer's disease, but what causes cognitive decline. This is a study that just simply looks at age and stress, in particular in this cohort of PTSD individuals. And what you're seeing here is a significant correlation in age, increasing age, being associated with a lowering of performance in memory in individuals who have had a long-term stress disorder. I think when I'm asked about this, I'm taking the real leap here and sharing with you some of the sort of practical advice I like to give people when we see this phenomenon of stress and distraction causing deficit. I think it's really critical that with age, and maybe not just with age, it's important to remember that given the magnitude of inputs that we can get these days, that it's important to realize that focusing on one thing can really change a person's performance. Giving a single item attention so that one can truly learn it can be particularly important. The last thing is, I always say, remembering that multitasking is for the young, not the young at heart. I'm not even sure it's good for the young. And, multitasking is our ego saying that we can do more things than we think we can. So it's important to realize that this challenge is probably lifelong, although we may be more sensitive to it as we age. So now I want to talk to you a little bit about a private-public partnership to start an important study that's thinking about the biology of primary prevention or of prevention of Alzheimer's disease. And this study you will be hearing a lot about. In fact, there have been several public service announcements recently released. This study is called the A4 study. And A4 stands for Anti-Amyloid Treatment of Asymptomatic Alzheimer's Disease. This is the first trial, just began at the beginning of this year, and I think the first patient was randomized last week, or actually began treatment, randomized treatment. It's the first ever trial designed to prevent memory loss in those people who we know have amyloid in their brain, but have no symptoms, have no behavioral, no functional, and no cognitive symptoms. So the idea here is to test a new investigational treatment, and I'll talk to you about that treatment in just a minute and show you what we know about it to date, that's an antibody to determine if it can prevent memory loss in those people who have no impairment at present, but seem to have the underlying biology of Alzheimer's disease. It's a real challenge. So the goal of the study is to determine whether the deterioration in memory that we know exists both in disease and in aging can be reversed by this kind of intervention. So a few facts, and I throw this out because as I tell you about this study, you'll say, you know, this is a very aggressive way to treat the potential of memory loss in people who have no disease. But I think it's really important to keep in mind that this is true, but it's 100% voluntary. And remember that first slide. One of the diseases that people are most afraid of is Alzheimer's disease and cognitive loss. So this is an opportunity, but it's completely voluntary, it's completely confidential, and there's no cost to the participants. There's monetary compensation for getting an individual to and from, and for the procedures that are involved. But it's a long study. It's more than 3 years long. And the investigational medication, which I'll tell you about in a minute, is delivered through IV, right, an infusion that takes place on a monthly basis. You can hear the story already. It's a very aggressive approach. However, I think it's important to keep in mind that people can withdraw at any time. And I'm going to try to remind you of this as I tell you what I think everyone's role is in terms of research. So this study is recruiting individuals who are 65 to 85, have no cognitive or functional problems, and have amyloid imaging that we can see in that PET scan that I showed you earlier. And the only individuals that are being recruited are individuals who have enough amyloid that we think that it would be equivalent to their having Alzheimer's in their brain, Alzheimer's disease, but they have no symptoms. So we believe that they're at risk for memory loss, and I'll show you the data that supports that. And they're being treated with an agent that's called solanezumab or placebo, and the idea is that hopefully this agent would reduce the rate of decline over 3 years. So this is a scan, and what I wanted you to see on this scan is that these are all healthy controls, and this scan is clear of Amivid. This is the official name of the agent, AV45, is Amivid. And here what you see is positive scans equivalent to positivity of if you had dementia or cognitive loss, and you had this much in your brain, I would say this person has Alzheimer's disease. But in fact, these people have no symptoms. Well, what do we know about these individuals? Well, if we compare their performance, particularly on memory tests, which are one of the most informing tests about dementia, what we see is that cross-sectionally, they have lower performance on memory tests. This is the Wechsler Memory Scale, verbal memory test. The difference here on other kinds of testing is smaller. This is the test, this is the kind of memory that we think is most likely to precede the onset of dementia. The other important thing here is all of these scores are above normal. It's just that there's a difference in the normal groups depending on which one falls into the high amyloid in their brain. So there's historical information that tells us that this accumulation may occur long before we see disease. This is a summary that was published a couple of years ago. It's actually a review of information. What you're looking at is the prevalence of Alzheimer's disease by age cohort in this red line. And this is from studies looking at the brains of individuals as they die with or without Alzheimer's disease. And what you see is that the prevalence of amyloid plaques increases in healthy controls over age, right? And what you see is this increase. Now, this is a much smaller number of studies than the Tobias study. This increase is really happening about 15 years before symptoms start to become apparent. Now, this wasn't one study. This is an assumption we've made from a bunch of studies that we've put together. I think the other thing to realize is that some of these individuals actually have subjective memory complaint as well, based on the likelihood of their having high or low amyloid in their brain. And that's what this slide is showing. But I think the one piece of data, and this is a small subset, this is only an abstract, the one piece of data that is the one that says, okay, maybe amyloid in the brain is a bad thing, is this study looking at individuals who have Alzheimer's disease, individuals who have MCI, and healthy controls. And what you're seeing is over a 36-month period, those healthy individuals who have no amyloid in their brain tend to have stable performance on memory tests. What you're looking at is verbal memory and visual memory. However, this cohort, right, that has healthy elders, right, but they have a positive scan, they have a deterioration in their memory. Again, this memory performance is only lower by half a point, and it's still in the normal range. But that's a trend that I find disturbing and worrisome. And in fact, it happens on both kinds of memory tasks. Okay. I want to take a minute to just point out something else to you, and that is the fact that here what we see in those individuals who have MCI, that again, there is there is a deterioration here. This is the group that's MCI and has a positive brain scan. They have a deteriorating performance. This group of individuals who have MCI, you'll see that they actually start out a little bit better at the beginning. They don't have amyloid in the brain, and some of them actually have a reversal. They actually have an improvement in their cognition. So again, in the presence of mild cognitive impairment, this imaging might be important. It might say we don't have to think we're on the slippery slope. We might actually be in a very different group. So here's the A4 study in graphic model. What you see here is the trajectory of normal aging. We think this is the trajectory of aging an individual who has Alzheimer's disease. And what our hope is that with amyloid treatment, this anti-amyloid treatment, that we can keep this line a little bit higher, that we can reduce that rate of decline. Okay, so the agent is solanezumab, monoclonal antibody, which binds to amyloid. It has been minimally effective in Alzheimer's disease, and I'm going to show you some of this data. This is New England Journal data in the intent to treat population of mild to moderate Alzheimer's disease. And what you see is that these are borderline. They're not really significantly better. However, in this figure, which again, I apologize for being a little hard to read, what you see is that, in fact, there are, in the mildest group, the ones who had the best Mini-Mental scores, you see some improved trend of benefit. Not significant, but somewhat better effect. So the A4 study is being called the secondary prevention study. It will recruit people who have amyloid in their brain. Excuse me for a moment. Pay attention to my time. Just wanted to see where we were. It'll recruit people who have amyloid in their brain, but have no symptoms. They'll be randomized for a very long period of time, 168 weeks, about 3.5 years. The recruitment number is huge. It's 1,000 individuals, 500 in treatment and 500 in placebo. However, the individuals will come in, they will not know whether or not they have amyloid in their brain. They will be scanned and they will be informed. So another risk of this trial is I have to tell you. And we don't really know whether or not it's going to predict that you move on to Alzheimer's disease, but we know it's probably not a good thing. So we will tell you, but for those who are negative, we don't know that you won't have amyloid a year later or 6 months later. And so those individuals will also be followed in a separate cohort called the LEARN cohort. In addition, we're going to examine the ethical component of disclosure of amyloid status to determine whether or not knowing adds an additional bad outcome. Perhaps not. Perhaps it actually helps people feel better because they have knowledge, but that's the idea of that study separately. All right, so I want to move on. I want to talk to you about another study that the NIA is also sponsoring. This is a study with intranasal insulin for individuals who have mild Alzheimer's disease or amnestic disorder. And what you're seeing here is some pilot data that has suggested that at least at the intermediate doses, that intranasal insulin can modify cognitive performance. And you also see this here. This is on a test known as the ADAS-Cog, the Alzheimer's Disease Assessment Scale, highly weighted for memory. And again, what you're seeing is a trend, but this is a single-site study with very few patients. And so now this study has been sponsored by NIA under the National Alzheimer's Plan. It received funding last year and is in its initial phases. So this is a 12-month study with a smaller cohort of 250 individuals who have some symptomatology, the same age range. Obviously, in a study like this, we can't include individuals who are on diabetic medications since the agent itself has a diabetic effect, an anti-diabetic effect. So you can see that the focus is on the research in both of these cases are on moving cognition and behavior and functional abilities to determine if we can slow the rate of decline, both in the symptomatic individual and in the non-symptomatic individual. So, when I finish presenting my slides, I'm asked by both lay and professional audiences, well, where do we stand? You know, can you really do anything to minimize cognitive impairment? And I like to remind people that while agents for your treatable conditions, to use them in people who don't have the conditions has shown no benefit. Certainly, there's evidence that it's worth treating your treatable conditions. High cholesterol, diabetes, hypertension, depression. All of the epidemiologic studies suggest that those individuals who treat these conditions actually have lower cognitive deficits. I think the other thing that's important is the concept of protecting your brain. I really haven't reviewed the data that we're now becoming so aware of about head injury in its mildest forms. And it's never too late to remind people to use seat belts and helmets, to avoid falls, to use safe ladders. You know, as the aging population becomes more active, the risk of fall can go up, the risk of injury can go up. And it's really a critical time to be sure that we focus on making sure that they've taken all precautions to protect themselves. And then finally, the concept of supporting research. I think this is really important. It's important, if you can, to participate, to encourage funding, to be a study partner. Many of the studies that I have mentioned to you have a lot of effort involved. And if it's not for you, that's understandable. But if it's for someone else, it's really helpful if they can get the support of a friend or a professional to say, yes, I understand why you're doing this, and I really support that commitment and that effort. You heard earlier today, and I want to reiterate it, low subject recruitment hinders every research study that's ongoing today. And one of the things that can be hard is at the individual basis, someone will say, I want to participate, and they'll be turned away. And they'll be turned away because of safety reasons or because of some specific of the procedure. So, for example, individuals who have serious hearing or visual difficulties might not be able to take part in the assessments where I can determine if there's a benefit. So they might be excluded. you might be on a concomitant medication that there's known to be a risk when combined with a new medication. So there are entry criteria that can restrict individuals' participation, but it's still worth finding out. I think the important thing is how to choose. I think it's important to select what interests you, working with people you trust. Perhaps you don't know them, but you can build trust by asking questions. Be honest about how much you can do. This is a series of links that I've left every year to talk about places you can go to get more information on Alzheimer's disease, but I really want to spend a minute talking about the last one, clinical trials. That website is incredibly valuable, and here is what you find if you go to that link. Clinicaltrials.gov has one of the easiest websites I have ever seen. In this little box, you can put in Alzheimer's disease and Maine, and you will get a listing. And here is a listing of 4 studies that have active open recruitment here in Maine. And this will change from day to day, from week to week. So you can go back to that website at any time. This is just a listing that I've put together, but again, when you go to the website, every piece of this is a link. You can click on the link, find out who's doing it, find out what the criteria are. If it seems beyond your scientific knowledge, you can bring this to your primary care physician. You can bring this to, and if you're the primary care physician, you'll have contact information. You can call and get more information. I really want to urge you to understand how important this is. You heard earlier today that Dr. Singer's group here in Maine is conducting some of these trials that are listed here. You have opportunities. You have opportunities to participate and to learn more. So I'm going to stop there, and it's just a reminder that I do nothing alone. And this is a group, my most recent group at my Alzheimer's Disease Research Center in New York at Mount Sinai. And I'd love to answer any questions and tell you that I thank them as well as you for your attention. Thank you.
Questions for Dr. Sano? And please, if you could speak right into the mic so we can kind of track them.
I was just wondering if you had anything to say about differences culturally and how, like in India, they have a much lower rate of Alzheimer's, any relation to turmeric, anti-inflammatory type things.
Right. So actually, that information has been challenged most recently, the fact that there's lower incidence in India. I think one of the things to keep in mind is that the lower rates or the higher rates are often determined by the way we assess a person's ability. And as all cultures move more to an industrial society, the likelihood that we observe the deficit of individuals is actually going up. So in fact, that's an important change. And as the demand for cognitive capacity to do your ADLs, your activities of daily living, goes up, the risk of seeing deficit goes up as well. However, you're asking me about, are there regional differences that might hint to treatment options? I will tell you that turmeric, which is one of the ones that has been studied, curcumin has been studied in a few clinical trials with no strong evidence of an effect. Now, I think that the interest is in the anti-inflammatory aspects of this agent. And there are multiple studies going on right now looking at anti-inflammatory effects on the brain that may maximize cognitive performance. Some of those might be on the mechanisms that we think are Alzheimer's, like plaque and tangle, but it might be even broader. And so it's very hard to figure out exactly how to design the study. Do you look at Alzheimer's patients? Do you look at everybody? Do you look at people who have risk for inflammation? So I will say that to the best of my knowledge, there's no strong evidence at this point, but I'd also argue it's because we haven't quite figured out how to design the studies to get the answers. So, question over here.
With regard to the vitamin E, can you speak to the dosing and the form? Which
Sure.
types of tocopherol?
Right, alpha tocopherol. It was a racemic mixture at a dose of 2,000 IUs in caplet form that is available in most health food stores. It was in caplets of 1,000 IUs, so 2 a day. So I will tell you that there are, I have to say the Alzheimer's Association had a hard time coming to grips with this study because there have been reports that vitamin E might have a risk in terms of increased mortality that was never seen in a clinical trial but was seen in a meta-analysis. And there's a couple of observations to be made from that. One is that that meta-analysis, all of the risk was seen in individuals who were primarily cardiac individuals, and none of those individuals were taking just vitamin E. They were taking lower doses, and they were taking a mixture of antioxidants, including high doses of beta-carotene. I think the reason I have less fear about any danger with this dose is because the veteran population is a sick population. They had 3 or more comorbidities. Many of them are on cholesterol-lowering agents. And we actually saw this trend to decreased mortality, increased survival. So I'm actually less worried about the side effects than many people have been in the past. So. Questions?
Other questions?
How about research part? Yeah. Yeah.
One more over here.
What is your impression of the whole David Perlmutter brain theory about
yeah.
high carbohydrate diet?
Right, right. So, one of the things about developing a model for a disease like Alzheimer's disease around these sort of global views of dietary trends is that it sort of equilibrates all conditions. And I would say that, we all know that certain aspects of any dietary trend that's in excess is likely to cause a lot of things that you don't want to take credit for, or you want to call as potentially bad. I think I don't see any particular effect on the brain in this particular disease. That's not to say that it couldn't happen, but I think it's really fascinating how little effect we get from diet. I mean, look at what we saw in those healthy individuals, 0.5 point on a mini mental over 6 years, despite the fact that they were getting great cardiac effects. So it's important to remember that in terms of dietary input, there are barriers that keep the levels from flaring, from going up based on your systematic intake. And I think that's important to keep in mind. So you don't really actually affect the brain quite so directly with routine or average amounts of agents. That being said, there may be other health benefits that certainly could play a role. So, Claire?
Mary. Thank you. Mary, Peter Whitehouse was here on Thursday and at another conference, and many people here today were at that conference too, and are probably suffering a little bit of a hangover effect from Peter's talk, which was entitled "The Myth of Alzheimer's Disease." So, Peter is very pessimistic at this point about finding a drug intervention that would be effective because of all the, he thinks it's a mixed pathology and having to do with all the lifestyle factors, and so there's a little bit of lingering pessimism, I think, that some of us may have after listening to Peter. And you have a much more hopeful attitude about finding interventions that are effective. Can you just put a different spin on optimism for eventually having success through clinical trials for what is clearly a distinct disease entity, but in people expressed who are expressing a lot of other things happening in their brains.
Yeah, I think this is really important. Anyone who lives with someone who has Alzheimer's disease knows it's not a myth. And the loss of cognition, whether we call it Alzheimer's or anything else, is just a frightening thing. It's where you lose the essence of who you are. And many of us worry about it for ourselves. And I don't think that tomorrow this is going to turn around. But you really do need to step back and look at the great view. When I entered this field, there were no approved treatments. The simple fact that there are improved treatments means that people ask questions much earlier about their cognition. There's not the... I remember in my first years in Alzheimer's research, families saying that they thought that this was a complete death sentence, that to think that their memory was starting to go was the end. And I think that while that is still a serious problem, we have become aware of the fact that we have made steps forward. And one of the things that I think is also a problem is that, and I'm a huge advocate of the Alzheimer's Association, but any agency that has advocacy at its root has to be sure you know that the problem is big, and it is, but it might be hard for them to tell you about the progress that we've made. The fact that people know this disease at its earliest stages, that some people now actually diagnose it themselves, saying, my memory's not right. That didn't happen. That was rarely heard of. The fact that a primary care physician will take a memory complaint seriously, even though they may not be sure they know what to do or everything that they can do, that alone is a demonstration that we've actually moved this forward. And I agree with Peter that no single treatment will come forward to reverse the disease. But that's not the way we make progress. It's not the way we've done it in oncology. It's identifying smaller and narrower conditions and finding ways to affect those conditions. It's not a global, I take this and I get better. It's, I have this aspect that I want to enrich or enhance, and I will do that to see if I can get a beneficial effect. It's really the molecular characterization of cognition that's going on right now that is very much like the characterization that we do in cancer. And I think it is, we have to take the time to do that kind of specification before we can expect to see any big movement forward. So I'm actually rather optimistic. We have new tools. We have ways to image protein in the brain. We have ways to image activity of the brain in the presence of certain stimulation. These are tools that will really help us tease out where we can make a benefit. So I'm very optimistic. So.
Dr. Sano, thank you very, very much. So you guys know me, but I'll use the opportunity to introduce my colleague and co-presenter, Judy Shaw, and tell you a little bit about Judy Shaw, because we are tag teaming today. We've done this several times, and it's a fun, if you can call this a fun presentation, I guess. But it's a very eventful and a very important presentation, and I think you will think so. Hopefully you will think so too when we finish. I want to tell you a little bit about Judy. And Judy Shaw serves as the Securities Administrator for the State of Maine Office of Securities, having been appointed in 2008. And Ms. Shaw began her career as Associate Legal Director and later Chief of Investigations for the New Jersey Election Law Enforcement Commission. In 1992, Ms. Shaw returned to Maine and joined the Maine Office of the Attorney General, specializing in insurance law. In 2001, she was appointed Deputy Superintendent for the Maine Bureau of Insurance. She serves on the Board of Directors and is Secretary of the North American Security Administrators Association, NASA. She also serves as chair of NASA's Legal Services Committee and previously served as chair of NASA's Enforcement Section Committee. NASA is the oldest international organization devoted to investor protection. Its membership consists of the securities administrators in 50 states, the District of Columbia, Puerto Rico, and the U.S. Virgin Islands, Canada, and Mexico. Ms. Shah is co-chair of the Maine Council for Elder Abuse Prevention, which is a coalition of public and private partners dedicated to reducing elder abuse and financial exploitation. She is also vice president of the Maine Jumpstart Coalition for Personal Financial Literacy, a private nonprofit educational organization that promotes financial literacy in Maine. So we are very fortunate to have Judy with us. Judy is a wealth of information, and I'm going to scoot through my part, and I'd like the majority of the opportunity to be for Judy to present and for us to have somewhat of a discussion if we can. So what are we talking about here? We're talking about EFI. We fondly call this EFI, but EFI stands for Elder Investment Fraud and Financial Exploitation Prevention Program. And this is a program that utilizes CME to educate medical professionals who routinely see older Americans or older adults as part of their practice about elder investment fraud, vulnerability to investment fraud due to MCI, mild cognitive impairment, recognizing that exploitation in their patients, and referral routes for further medical screening and the reporting of suspected fraud. So this is really what we want to talk to you about today. The program, although it says here is currently running in 28 states, it's running in 29. It may be running in a few more, but we think it has really plateaued off at the moment. But there, thus far, has been approximately 3,400 health professionals throughout the entire state, throughout the entire country, that have been educated around the issue of EFI. And when our University of New England Geriatric Education Center received our supplemental funding award to train health professionals around issues of Alzheimer's disease and related dementias, Judy and I had a conversation and thought, you know, EFI really has most to do with mild cognitive impairment, and we know vulnerability, and thereby Alzheimer's disease. So what a perfect opportunity to bring EFI into our fold, into the Alzheimer's training as a breakout session, so that we could continue this effort to train health professionals in our own state of Maine. So as I said this morning, and some of you perhaps were here, this will be our fourth EFI session. We have included EFI in all four of our Alzheimer's disease trainings in Freeport last March, in Bar Harbor last June, in Presque Isle in October, and now again here. So Maine hopefully will be doing their part in relation to EFI. This is the smallest group we have had. But we have trained a large number of folks. So the EFI prevention program was established as a collaboration between many groups: the Investor Protection Trust, the Investor Protection Institute, Baylor College of Medicine, the National Adult Protective Services Association, the North American Security Administrators Association, the state securities regulators. In addition, the EFI folks, and I'll talk to you about them in a moment, they really thought that they could move EFI out much more seamlessly, if you will, or be able to disseminate the evidence-based practice EFI model if they partnered with other collaborators. Therefore, they also are collaborating with the American Academy of Family Physicians, the AHEC groups, which many of you may be familiar with, which is the National Area Health Education Center organizations, as well as the National Association for Geriatric Education Centers. There are several of my GEC colleagues throughout the country that are also doing the EFI program. And the EFI program, as I said, is an evidence-based program, so many of the slides that I'll be showing you today are the same slides that go nationally. There's been a little bit of tweaking here and there, but it's pretty much of a slide deck. that we teach from, and we'll deviate here and there. The initial project team was led by my colleague, who is another director of a geriatric education center, Bob Rausch. And Bob is the principal investigator on EFI. He is also the director of the Geriatric Education Center at the Texas Consortium, GEC, in Houston. And we were really fortunate. Bob really encouraged us to take on the EFI project. As you'll see, we'll show a little clip in a few minutes, Bob is quite compelling. And he's a wonderful fellow. He is a Texan. He wears cowboy boots, and he has a wonderful Houston accent. And so Bob really encouraged us. We got together, and we brought EFI to Maine. And for our first EFI presentation, we actually brought Bob up here. Judy brought Bob up here. And he did our first presentation at the University of New England, excuse me, on the Portland campus. So I will try to be Bob, as I say. I'm not a substitute for Bob Rausch, but we'll see what we can do. These are the disclosures. I also disclose that we are federally funded. I am federally funded, our GEC, by the Health Services and Resources Administration. So the objectives today, essentially, as we said, this is an evidence-based program, and we're really soliciting the support of health professionals in Maine to add EFI on to their clinical practice or within their organization. So we really would like to present to all of you the key factors that increase an older person's vulnerability to elder investment fraud and financial exploitation. We've talked a lot about vulnerability. For those of you who were at the other two-day program on Thursday and Friday, and again here today, vulnerability really is the word. And we're really trying to identify our vulnerable patients that are very high risk. We want to be able to help to describe some of the common financial exploitation schemes and practices that are very compelling, and Judy will share a lot of those with you. They're frightening, they're scary. People are losing their small and large pots of money unnecessarily. And we would like you, when you leave today, to be able to describe when to and where to refer patients. Once you have identified these patients in your practice, how do you help to protect them and get them the information and the security that they need? I'm really just going to say that we're speaking to the choir here. We don't really need to talk much more about aging demographics. We're the oldest state in the country. I believe that, I think maybe it was Cliff or might have been Mary Sano who said that there will be 9 million folks with Alzheimer's disease by the year 2050. So there's great cause for us as health professionals because we are the people that older adults trust. We are the people that they will confide in if we help them and we ask questions in a certain fashion and retrieve this information to the point where then we can help them do something about it. So the project goals for EFI, again, are to raise clinical awareness and provide information and resources. Most of you, hopefully, unless there's anybody really young here, will recognize Mickey Rooney. And Mickey Rooney, he testified to the Senate Special Committee on Aging, March 2nd, 2011. And he said, and I quote, "To those seniors and especially elderly veterans like myself, I want to tell you this, you are not alone and you have nothing to be ashamed of. If elder abuse happened to me, it can happen to anyone." So think about that. We've talked about vulnerable populations being high risk, and they're large and growing. We also know that when people do not have the finances that they need, that this is all-encompassing. It affects their basic security needs. It affects their ability to purchase food to go on the table. It affects their ability to purchase the medications that may or may not keep them healthy. It affects their opportunities to connect and access resources. So that financial health is very similar to its influence on overall health. About a third of elders live within 150% of the poverty level, and on the average, the savings of a 50-year-old boomer is approximately $50,000. But that doesn't really make any difference. Whether or not someone has $100 or whether they have $100,000 or $1 million, it makes no difference. This amount of money that they've saved is theirs. They've worked hard all their lives. They've worked long hours. They've made sacrifices. And once this money is lost, it is not easily able to be regained, whether it's from a savings or otherwise. So that this little pot of gold, no matter how big or how small, is their pot of gold. And that is what is most important. And I think that, whoops, right here, this is really where we're at. Right now, the current resources exist mostly for patients only after the harm occurs to them. There's little available to prevent FE. So that's why we're here, because we can create awareness. And if we create and heighten awareness, maybe we can prevent some of these circumstances from happening. Approximately 30% of all elder abuse cases are for financial exploitation. And there's been 2 studies by Acierno and Lohman, and those studies are nationally representative studies that have found between 4 and 5% of older adults in the US have been victims of financial abuse. And this is a similar prevalence to MIs, to heart attacks. And it's higher than that of CHF, which most of us have a lot of familiarity with CHF. We're going to show a short video clip, and you'll get to meet Bob.
He made you feel like he was a good old boy, and you were his best friend.
Hello, come in.
All you need to do is bring money, and that was the big sell.
How much money do you want this time?
7,000 should take care of us for now. Be very happy with this.
I'm sure I will, with you handling it.
He looked like a nice young man. You know, go to church every Sunday and all that.
Elder financial abuse is a national epidemic, especially when it comes to seniors with some form of cognitive impairment, such as dementia or early Alzheimer's. Every 5th American now over the age of 65, that's almost 7.5 million people, have already been victimized by financial fraud, making these seniors our nation's most exploited citizens.
1 in 5 of everybody you see on these sidewalks in about 20 years will be age 65 or older. In 20 years after that, 50% of them are going to have some cognitive impairment, dementia, that will make them extremely vulnerable to being defrauded of their money.
Each year, con artists swindle elders out of more than $2.5 billion. Being a victim of fraud can make you dead broke. Older people just don't have time to make up for the losses.
Older people control 70% of the wealth in this country. So the money is there, and you have professional scam artists who know where the money is, and they've developed a great set of tools to go get it.
Most licensed broker-dealers and investment advisors are legitimate, but there are a few bad apples, like there is in everything else in life. And they can really come forth with a product that sounds too good to be true, and it probably is, and they use it like you would an instrument of mass destruction. It's a very dangerous situation today, and it's getting more dangerous.
People look at me and figure, number 1, she's old. Number 2, she's a woman. Number 3, she won't be able to do anything about it anyway.
So why do we become more vulnerable to financial fraud as we age? What actually happens to our brains?
The older brain shrinks in size. There's less fluid in it. It's not as big as it used to be. The neurons, electrical signals, the pathways for cognitive function are all impaired. Then when you overlay cognitive impairment on this normal age-related change, then you have an individual who is not fully capable of making sound financial decisions.
Karen Wilson understands that all too well.
She was incapacitated. She was in a situation where she was completely broke. She had no money left.
Helplessly, she watched as her mother's cognitive capacity started to decline.
She was really a wonderful mother, really sweet and calm and caring. I'd taken her shopping and we went into a jewelry store, and just for fun, like a breakfast at Tiffany's moment, I looked at a ring and I said, "I love this, do you?" And she said, "Yeah." She said, "I'll buy it for you." And I said, "Mother, it's like $60,000. And she goes, "That's okay, I have my checkbook." And I knew she was being serious, and I knew that she was not okay mentally.
People with early onset dementia are more willing to gamble literally with their money. And of course, some dishonest quote-unquote money managers take advantage. And the result? Countless horror stories.
I have an aunt who lives in the Midwest. One afternoon she got a phone call, and during this phone call she was convinced to send $5,000 Western Union, which she did. So she called the police and they tried to trace it, and of course by that time the money was gone.
A gentleman in Houston was treated for having fallen to the Nigerian email scam. He had about $750,000 and he lost all but $35,000. And he felt like if he gave that last $35,000, he got all his money back.
Even legitimate, everyday investing opportunities can become a nightmare.
We had one example where a 90-year-old woman was advised to go into a 15-year or 12-year CD, which was totally inappropriate. She made the investment. The person that sold it to her was legitimate, but used very bad judgment, and it really wasn't suitable for her.
Yes, it's very frustrating. They look at you and think, "Oh, well, she doesn't have anything left up there. We can rip her off and it'll be okay." And it's not okay.
Hand in hand with financial abuse is the shame of having been taken. It's embarrassing to fall for a high-pressure sale or a friendly voice on the phone promising fantastic returns.
We decided to take her checking account out of her hands because, there were checks being written that we couldn't document. I mean, we should have started preparing 15 or 20 years earlier.
When a loved one is in cognitive decline, family members can be in massive denial, unable to reverse the roles of who was caring for whom.
She died in a deficit situation, somebody who'd worked that hard her whole life. I'm guilty. I wasn't there. I didn't do the right things.
So what can we do to stem the rising tide of financial abuse? Do medical professionals have a responsibility to protect our vulnerable elders?
Any healthcare provider knows that they have an ethical and legal responsibility to report elder abuse. Financial fraud is elder abuse, pure and simple.
Talking together about financial fraud, the same way you would discuss high blood pressure or diabetes, is a good prescription for prevention. So, becoming educated is key.
On our intake form in our office, we do have a question, are you having financial difficulties or stress? And if appropriate, we can help refer people to community resources.
Even people with mild cognitive impairment lose the ability to make good financial decisions.
People with mild cognitive impairment can go to the opera, play golf, go out to dinner with friends, have fun, almost be like their old selves, with the exception of managing their money. They make financial errors 4 times that of persons who don't have mild cognitive impairment.
There are signs that can help healthcare providers and family members identify a potential problem. Has a patient or relative become socially isolated? Have they made questionable financial decisions or been asked to change their will? Have you noticed deterioration in their ability to make daily decisions?
The worst thing you can do is be disconnected and isolated.
your parents need for you to take control. They need to have one of their children manage their health care and manage their investments at the same time.
Everything under control?
State securities regulators and medical professionals, in partnership with Adult Protective Services, have recognized this perfect storm and are tackling it head-on, knowing full well that the tsunami of aging baby boomers will double the number of older Americans, which could double the risk of exploited seniors over the next 20 years.
Thanks a lot.
Everybody needs to stop and think of themselves as someday being a frail, older person and asking him or herself, what type of systems do I want to have in place when it's my turn?
We know that it's difficult to get involved in somebody else's business. It's not fun. It takes time. There's certain liability involved, and we recognize that. And we at the state level are going to try to ease that so that it's minimal.
That's our goal, is to help everybody have as good an old age as they can.
I have complete faith in people. I keep thinking that maybe they just have had a bad day or a bad situation. You kind of hate to give up on people. So you just keep hoping that things get better.
Well, Bob Roush and his team and all of the collaborators all over the country have really done a wonderful job trying to increase awareness so that we're, again, trying to recruit all of you folks here sitting in this room to do what you can. And we passed out the pocket guide, which is the laminated piece. And we also passed out a patient education companion to this that you can use in your practices. And essentially, the pocket guide really is a checklist of situations associated with high risk. It's the red flags in the patient-client history that you need to be aware of. It's the red flags in the clinical observations in your encounter with the patient. And then it's an opportunity to ask questions about financial capacity and to help to frame some of the language, because the language is not so easy sometimes to broach with patients. How do you say this about something that's a very sensitive topic? And then, importantly, what types of referral sources may be needed based upon whether or not this is social assessment, need for help with managing money or other care, legal advice or protection, fraud and exploitation resources, or further medical evaluation. And then you'll also have on your inner right-hand sleeve, all the resources that are available. And the very back of the laminated flyer is a financial concerns checklist that could be incorporated into your practice, into an office practice, so that as patients are waiting in the waiting room, they can be clicking off and answering these questions, and then they'll go to the provider, and then the provider or the staff can identify whether or not these folks perhaps need to be assessed further in relation to high risk and vulnerability. So we're asking for you to consider this as an addition to your prescription, to add discussing dangers of financial fraud to essentially a prescription for older adult health. We know that vulnerability demonstrates characteristics and performs behaviors that are associated with subsequent morbidity, disability, and death. The definition of financial capacity is the ability to make and execute decisions consistent with personal preferences and values regarding finances. The definition of investment fraud and financial exploitation is the illegal or improper use of another individual's resources for personal profit or gain. And undue influence is when exploiters, whether family, acquaintances, or strangers, use their power to deceptively gain control over the decision-making of a victim, and often involves financial exploitation. I'll let Judy talk about the traits of the caregiver, because I think that you often do that. and we'll move along here. The clinical assessment, when you're clinically assessing vulnerable older adults, again, it's reasonably simple. This is a very simple, quick, evidence-based assessment tool that can be used in the office. Here is our laminated copy that we've given to you. And the red flags in the patient history, again, you folks know all of this. If someone's socially isolated, if they have just recently experienced the death of a loved one or of a spouse, if they are dependent upon another person for care, they can no longer travel, they can no longer drive, they're housebound, either their instrumental activities of daily living or their activities of daily living are now impaired. If they have financial responsibility for an adult child or a spouse, if there's alcohol or drug abuse, and if there's depression or mental illness. What we do know is that in relation to depression, 20% of older adults have major depressive disorder or some kind of symptoms of depression. And we know that depression is a risk factor. When someone also is being abused, depression increases and leaves them more open to exploitation. From a clinical observation, you may or may not have seen patients come into the office or patients come into a practice with a caregiver or a family member. The patient seems very fidgety, very fearful, very anxious or distressed. They may be suspicious or delusional. There may be cognitive issues. The caregiver may keep this person really close to the vest, might put their arm around the caregiver, and really use their nonverbals to look right into the eyes of their loved one or the person that they're caring for, giving them nonverbal cues, not to say anything, to be quiet. Cognitive issues, we know that, again, mild cognitive impairment, dementia, and changes in executive cognitive function in particular create vulnerability. People with mild cognitive impairment are 4 times more likely to make errors than controls. And it was mentioned on the video that damage to the prefrontal cortex makes affected elders less risk averse. These are folks that are willing to gamble, and they gamble away their money. Right. I'm going to scoot through these because I think you folks are very aware. Neglect and vulnerability. If you see one of your patients that has all of a sudden a change in appearance, change of hygiene, this may be someone who has neglect, whether it be self-neglect or neglect by the caregiver. And neglect accounts for most of the reports of elder abuse. So, questions in relation to how you can introduce the topic to your patient? You can say, in the course of your exam, we find that some older adults worry about money. May I ask you a few questions about this? Or, I just read an article in the New York Times or the Wall Street Journal or your local paper about older adults being financially exploited. And I thought I would talk to my own parents about this. And I wanted to talk to my patients as well. Does this ring a bell? Does it sound familiar? Is anything like this happening to you? And does anybody have opening questions that you've used in the past that have worked well for you and that are comfortable? Questions are tough.
I just had one come in last week when I was at work, and it was about a grandchild taking advantage of the grandmother.
Okay.
And actually what she did, she persuaded the grandmother to give her permission to take a lien out on the home, which was already clear. And she owed nothing on it. She ended up with $60,000.
Oh my.
And that was, it's been a while that took place. However, she found out about it now because the granddaughter chooses to leave the home and leave the bill behind.
Ah.
So the only thing that I could possibly tell her, because the hardest thing I think in a nursing home to do is persuade somebody to allow me to call for them, to report it, especially when it's a family member. So basically,
And-
I don't even know the people's names.
And we as health professionals, we are mandatory reporters. So we have obligation. And as I believe Bob said in the video clip, this is our job. We need to protect our vulnerable elders, and we are all mandatory reporters. Thank you for that. This is a fellow by the name of Dr. Robert Parker, who had attended one of the FE sessions, and they did a spot on him in the New York Times as he used the pocket guide as his guide and had found a patient in his practice with undergoing exploitation. Here are other questions. Who manages your money day to day? How's it going? Do you run out of money at the end of the month? Do you regret or worry about financial decisions you've recently made? Have you given power of attorney to another person? Or have you signed your mortgage away or whatever? Do you have a will? Has anybody asked you to change it? These are all common things that happen to folks every day of the week, and Judy will give lots of stories. So I think I'm just going to click through these, the questions that will, I believe, help you when you're talking to your patients are listed here. And I think I would like to hand it over to Judy. These are referral sources. They're also on the back here, but these are some referral sources in Maine in particular. And the slide deck will be up on the website as well.
Thank you. I really am very excited to be here today, and what a wonderful time for you to be having your conference, because as I'm sure you may have discussed or you all know, tomorrow is World Elder Abuse Awareness Day, and Governor LePage did sign a proclamation also declaring it Elder Abuse Awareness Day in the state of Maine. Approximately 33,000 reported cases of elder abuse in Maine every year, and that is significant underreporting. We know there are a lot more. We want to focus today on the financial exploitation piece of it. The most common form of elder abuse is financial exploitation, but we also know that it does not travel solo. If you see financial exploitation, you are likely going to see other forms of elder abuse, self-neglect. Unfortunately, you may see domestic violence, and you may see sexual assault, which is very sad, very frightening to think that a child or grandchild would inflict that type of pain on a parent or grandparent, but I'm here to tell you it does in fact happen in Maine. Mr. Madoff, take a good look at his face because you are looking in the eyes of a sociopath right there. You know, when you see criminals, they say he's skulking from his penthouse. He doesn't look like he's skulking to me. Normally, you know, people would have a hood over their head. He's looking straight into the camera. He has no remorse. People begged, literally begged, to have Mr. Madoff take them on as a client because he knew exactly how to play the scam game. He knew to emphasize his credibility, the fact that he had been in the securities industry for a very long time, that he had been on the stock exchange, he was chair of the stock exchange, and he also would tell people, well, you know, I can't take anybody else on right now. So we're going to talk a little bit about some of the typical techniques that scam artists use, and Mr. Madoff certainly used a great number of them. Scams affect most anybody. You can be wealthy, you can be poor. You can be a man, you can be a woman. Actually, truth be told, it's usually men who get scammed more frequently than women. The men also don't want to report it because they're embarrassed. And it's usually, we find more often, very well-educated individuals have a tendency to get scammed more frequently. More so when we talk about the younger ages, when we get into the elderly, it really is a very clear connection, pretty strong connection with cognitive abilities. That whole financial functioning part of your brain, and I'm a lawyer, not a medical person, so forgive me if I say don't laugh at me if I say something totally stupid from a medical perspective, but clearly it's the ability to do, the math and the calculation, the financial pieces that start to decline. My mom has some cognitive issues going on, and the last time she came to visit, we went out to a restaurant to dinner, and she struggled completing her bill. I didn't want to do it for her, I wanted her to do it. And I peeked over and I said, Mom, that seems awfully high. Why does it say $65? And she said, well, I just put the tip down. Well, the bill was $15. And in her mind, the correct tip was $50 for that. So it's that ability that starts to decline very quickly, as you know. Anybody here ever heard of the Office of Securities before today? No. I was on Facebook yesterday. Facebook has been bugging me for about a month and a half to put where I work into the little line. So I thought, oh, for gosh sake, I will finally put it in. When I put it in, it said invalid entry. So either that means I don't go to work on Monday, or I got to do a better job marketing my office. So this is my first attempt to market my office a little bit. We are an agency of 14 individuals. Essentially, we're the state equivalent of the Securities and Exchange Commission, but if you'll keep this little secret, don't tell my friends in Boston, I think we're a little more nimble, we're a little more effective. We're just able to get out there. I love my friends in Boston at the SEC, but we can actually be right there and take the phone call. One of the requirements in my agency, and I don't think my staff complains about it. If they do, don't tell me, is that you will always get a live person when you call my office. I think that's absolutely critical, particularly if we're dealing with older investors who are calling our office. What we do is we license investment professionals, stockbrokers, investment advisors, financial planners, the Edward Jones firms of the world, as well as the smaller ones. We do investigations. We have 4 investigators who investigate investor complaints. And we also, we may get an investigation, a complaint, and we start to investigate it, and it looks like it's criminal in nature. We will continue to do that investigation, and then we will refer it to the Attorney General's office for prosecution. So we do full level of investigation. We enforce the securities laws. That includes not just licensing the professionals, but also registering the stocks and the bonds and all that sort of thing. And we also have an education and awareness component as well. We try to get out there to raise awareness about all forms of financial issues, but our main focus falls on the elderly, because they're the most vulnerable. So we really do go out, we do presentations in retirement communities, we do these types of presentations, raising awareness. The only way to combat elder abuse and financial exploitation, in my view, is at the community level, and it requires everybody, all of us in this room and everybody else, to get together to take care of it. Investment products and vehicles, I'm not going to spend a lot of time on this. Stocks, bonds is what people typically think about. But there are other things that can be securities, promissory notes, real estate, groundhogs. There's a Supreme Court case that said investment in a groundhog farm was, in fact, a security. So it's very broad what can fall into that category of securities. Basically, when we talk about securities fraud, investment fraud, if somebody is going to sell you some form of investment, they have an obligation to make sure that you have all the information you need to make an informed decision. So if they have not given you that information, or they've lied to you, that's basically securities fraud. If they tell you that I want $7,000 so you can invest in my groundhog farm, and then they go take that money and go to Hollywood slots, then they've just committed securities fraud. So it's really quite that simple. A security basically is any time you give somebody else money and say, you go do whatever it is you're going to do, but make sure I get my money back plus. And that's basically a security. As I said, broker-dealers, investment advisors, they need to be licensed by our office. The difference between a broker-dealer and an investment advisor really is a broker-dealer is somebody who's going to be working for Merrill Lynch, Edward Jones for a commission. an investment advisor, the majority of which in Maine are 1 or 2 person firms. They're really going to be working for you for a fee based upon the amount of money that they're managing for you. They have a fiduciary obligation, which means they have an obligation to put your interests first. A stockbroker does not have that obligation to put your interest above their own. You should expect, so we know about the scam artists. We'll talk about the pure scam artists that are out there. But if you're dealing with a financial professional, I'm sorry to say that they can also go off the ranch. And so it's really important that you know who you're working with. The first thing that we would like people to do before they start to work with a financial professional is call our office and ask us to do a search of their license record. We can tell you if they have any type of criminal history. We can tell you if they've had 5 bankruptcies in the last 10 years. You could still work with them if you want, but wouldn't you like to know that the person that's managing your money hasn't done such a great job managing their own? So we definitely encourage people to contact our office to get more information. You are entitled to lots of information about your advisor and lots of information about any securities they recommend. So if we're talking about a licensed professional, here are some of the common scams that you're going to see that maybe a broker-dealer or an investment advisor has been engaged in. And I want to tell you that we have received calls from medical professionals before who have just helped their patient get in touch with us because they think that maybe the financial advisor has given bad advice. I'm going to give you one example. We had a 92-year-old individual in the state of Maine who was approached by his insurance agent. His insurance agent, Mr. Bean, had, I love that name, had approached our 92-year-old investor to say, listen, I found this great real estate opportunity in Wisconsin for you, and what I want to do is cash out this annuity that I sold you just a couple years ago, and we're going to take the money from that annuity and we're going to invest it in this real estate in Wisconsin. You're going to make way more money than you would make on the annuity. So here's the problem. First of all, the minute they cashed out the annuity, there were all kinds of charges, additional charges for cashing it out early. So I think it was about $18,000 right there. The second part is Mr. Bean, insurance agent, did not do any research on the individual who was behind the real estate transaction in Wisconsin. In fact, he didn't even have the good sense to Google Earth it to see what the property was. The property was actually a big bunch of swampland, and the man who was behind that real estate investment was on probation because he just got out of federal prison serving 8 years for securities fraud. So we were not able to get the individual in Wisconsin. We did take action against Mr. Bean. He paid a fine. He is in the process of paying back the money. But unfortunately, it's going to the estate of the investor because the investor passed away. Just one example of how financial professionals, we put our faith in them. That's why it's so important to check in advance. And it's so important to make sure they have done their due diligence on the investments. Common types of fraud that we see, affinity fraud, I don't know if anybody's familiar with that. It's basically an opportunity where the scam artist tries to say, I have some similar connection with you. Oftentimes it's a religious connection. Sometimes it's the deaf community. We have had a couple of cases in the state of Maine where a scam artist has reached out on Facebook, as a matter of fact, to the deaf community to say, we want you to give us some money, and on such and such a date, you're going to get all your money back with this incredible rate of return. The most recent one, affinity fraud we had, was something called Profitable Sunrise. And the idea behind Profitable Sunrise was if everybody gave $100, and then they would come back and say, oh, just another 100, another 100, that you would get a modest rate of return of 5% per day. 5% per day. So what people heard was, oh, 5%, that doesn't sound too good to be true, but they didn't hear the per day. So if you do the math, it's something ridiculous, like 400% a year or something like that. And the idea was you would get all that amazing money back on some sort of special Visa card on Easter, profitable sunrise. So it had this religious connection. And when we, as a matter of fact, it was running in Canada as well as the United States, when all the securities regulators started issuing orders stopping it, we were getting hate mail from the people who invested because they were saying, oh my God, now I'm never gonna get my money back. Look what you did. And what the scam artist did as soon as we started issuing those was he moved his server, his web server, to China so that we couldn't track it. Very common for the scam artist to do that. The other one I just want to emphasize on here because of what the individual was saying in the back is abuse of power of attorney. Elderly people will give, any of us, will give a power of attorney. You know, I may someday give my son or daughter power of attorney. One of the things you should listen for, we often hear elderly people say, my daughter is my power of attorney. Well, unless she's a piece of paper, she's not. Because a power of attorney is nothing more than a piece of paper that says, I am giving you this authority. But oftentimes, elderly people hear that as, oh, well, I'm sorry, I have no control over my money anymore because I gave power of attorney to my daughter. No, you can still control it. You can see, is your daughter, in fact, abusing that power of attorney? And guess what? You can revoke it. So it's important to keep in mind that it isn't the end of it. They often think about it that way. So it's important that you know what resources are out there. Legal services for the elderly is a really important resource to have in your bag of tricks in the state of Maine. Maine, I think, may be the only state in the country that has a nonprofit legal services organization for the elderly that provides free legal services to anyone age 60 or older. So it's important to just know what resources are out there. Power of attorney abuse is very prevalent and growing. How to spot a con artist. I tell people if you want to know how to spot a con artist, take a couple hours and just sit and watch Home Shopping Network for a while. This is what scam artists do. They look at legitimate businesses and they look at the ways that legitimate businesses operate, and then they exploit that legitimate way of operating. Always high rewards. If they're saying you're going to get a high rate of return, and particularly in a very short period of time, with no risk, gigantic red flag. If you're going to get a high rate of return, there's going to be a high rate of risk. You have to decide whether or not you want to take that risk. But if it says no risk, high returns, high rewards, no good. High pressure sales techniques, spelling and grammatical errors, especially with the use of email and the internet. If you see a lot of spelling and grammatical errors, usually it's either a kid who's really clever or it's a scam artist. This is only for you, a select group. That's one that Bernie Madoff used. You need to respond right away. It's a limited time only, right? That's the little clock ticking on Home Shopping Network. Advance payment. This trips people up all the time. This happened to my mom. She got something in the mail saying she had won the Australian lottery. All you have to do is send me X amount of money. And my sister said, Mom, it's a scam. And she said, well, why is it a scam? And Kathy said, well, if for no other reason than the fact that you have to send them money in order for them to send you money. And she said, well, it must cost them something to send it from Australia. Well, it's hard to help people understand that a legitimate business, that mailing cost is a cost of doing business. A legitimate business is not going to charge you if, in fact, you've won anything. Set aside the fact that it's actually not legal in the United States to play foreign lotteries. So if we can get that message out, maybe that will help people as well. Cash only or checks made out personally. This is also very important. If you have a client or a patient who is saying that they're giving cash to a financial advisor, or they've written the check out directly to the financial advisor, that's bad. Call me right away or encourage them to call me right away. checks should be made out to the custodian or the broker-dealer firm. Providing paperwork later is never a good thing. Asking you to sign blank forms and documents is bad. And always we hear about the offers that are too good to be true. These are some examples, and I'm just going to highlight a couple on here, but some frauds I'm sure you've heard about, the call from Mexico or Canada, your grandson's in jail, send money quick, that type of thing. Receiving the check in the mail, you've won a big prize, send the processing fees, or the phishing scams where it looks like you're getting something from your bank or credit union and they want your account information. That doggone Nigerian prince, I mean, we've had enough of him, haven't we? Work at home or other business opportunities, these are very, very prevalent, particularly web-based ones. My mother received an email from what looked like from my state of Maine email account, and it encouraged her to allow the scam artist to deduct $50 a month automatically from her checking account so that she could have a web-based business. And they would set up a website and she was going to get money back every time somebody hit on the website. Now, my mom doesn't understand how the internet works at all. She thought I would not steer her wrong. This is from Judy. I mean, this is what she does for work. So she didn't call and check with me. So we didn't realize this was happening until, fortunately, the credit union noted this kind of strange money coming out of her account. My sister happens to be on Mom's account, and they called my sister and they were able to sort of unravel it before it went too far. But they're clever. Scam artists are creative. The last one I just want to mention, these are all legitimate cases that we had in our office. Investing money in real estate. Mr. Eric Murphy from this area actually is sitting in prison for a while because he had been a very well-respected, I understand, commercial real estate broker, but fell upon hard times, went through a very difficult divorce, convinced family, friends, neighbors to invest in non-existent commercial real estate venture. And as yet to be built resort in Tahiti, it actually was the castle at Polgardi in Yugoslavia, as I recall. I think an 88-year-old gentleman in the state of Maine was convinced by a former mayor of a community in Connecticut and a former insurance agent / stockbroker to invest $600,000 in what he understood was going to be the castle at Polgardi, a resort where there was going to be this wonderful golf course designed by Greg Norman, maybe, or Jack Nicklaus, one of the big golf pros, and it was simply non-existent. Mr. Renison, the former mayor, was prosecuted by the federal government, and he's serving some prison time, we took action against the stockbroker as well. A pay-per-view program, we had a retired couple in northern Maine who had worked in the mills all their lives. They had managed to save about $192,000. They had it in mutual funds. And Mr. Philbrook, an insurance agent / stockbroker from New Hampshire, convinced them that they should cash out their mutual funds and give him the money, and he would invest it in a pay-per-view program that was going to be hosted by Carmen Electra. I'm not sure that they really understood how pay-per-view programs worked, not because they weren't intelligent enough, but just not something they were particularly interested in, but they trusted him. They believed that they, again, were going to get a big rate of return every time somebody watched that pay-per-view program. In reality, Mr. Philbrook's son didn't fall far from the tree. He had embezzled from his employers and he was in prison. And the only way for him to get out of prison was to pay back the money. So Dad took the $192,000 and paid restitution for his son, so his son could get out of prison. And now Dad is going into jail instead, in fact, is in prison at the current time. It is very common, unfortunately. We have as I said, 4 investigators, each of them currently carrying approximately 20 open investigations at the current time, the majority of which involve elderly investors. You know, we want to try to help people know and understand just, I think the most important message on this whole slide, you know, we've talked about checking, watch your account statements, don't send money directly. Most important message for anybody who gets a phone call is hang up. It really is the best thing to do. Investigate, check with our office. You can refer people to our office. You can help them file complaints with our office. We have complaint forms. The other thing, the real message I want you to walk away with, this particularly comes from the Maine Council for Elder Abuse Prevention. We're all working very closely together to form a community, form a safety net. We want you to be part of that safety net. There is no wrong place to report. If you report to APS and it's a securities case, we are developing a memorandum of understanding with APS. They will get that case to our office. If you refer to our office and it should be an APS case, we'll get it to APS. If it should go to law enforcement, we'll get it to law enforcement. If it should go to the FBI, we'll get it to the FBI. These are all organizations we work closely with. So the most important message for all of you is please report. Encourage your patients and clients to report. We can help them get to resources. If they need money for fuel oil, we will help get them connected with the Area Agency on Aging, or they will get them connected with us. We'll get them connected with legal services for the elderly. But the only way we are going to make progress with elder abuse and financial exploitation is if we team up and we all work together and we form that community safety net. I'm very grateful for your time and attention, and we would be happy to take any questions you have.
or cousin or niece moved in with an elderly veteran, because I work for the VA, and we'll take care of you, but you need to sign the house over. Yep. And they didn't seem to understand that if they got the house, they got the veteran too. And
Yep.
but the money pretty much found ways of leaving. And I wasn't aware that there was an agency such as yours in other states. Is this something new in Maine, or are other places developing this sort of program?
So the first thing I want to say is thank you for the work you do with the veterans. My son is currently serving in the Marine Corps, so thank you very much. That's special to me. There are state securities regulators in every state. What I will say is that many of my counterparts are equally active in this space. Elder abuse and financial exploitation is something I'm very, very passionate about. And so I have tried to get my agency to be out front. For example, we have worked with the Council for Elder Abuse Prevention to train banks and credit unions, and our agency has agreed to be the point of contact for all referrals that do not otherwise go to Adult Protective Services. So I would say that our agency perhaps is trying to be a little more out front and proactive, simply because it is a priority for me. These scenarios that you mentioned are very common. One case that I received was very sad. An elderly woman who lived in Connecticut, her son and daughter-in-law convinced her to come to Maine to build a home for the three of them to live in, and they would take care of mom, and then son quite unexpectedly passed away, and the next call I got was daughter-in-law was evicting mom from the house. That call came to me from the mother's investment advisor. So as you can see, we encourage everybody we work with, just give us a call and help us get connected with the victim, and then we can take it from there. But if you can make that phone call, we can make a difference. Any other questions? Yes, ma'am.
If I'm aware that there's an elderly individual in a residential care home who has a power of attorney, who is supposed to be paying that person's bills for them because that elderly individual can't manage that really on their own anymore, and suddenly the bill isn't being paid, would it be appropriate to call your office or Adult Protective?
In that scenario, I would say call Adult Protective Services, but then I'm going to go back to there's no wrong place to call. So if you were to call us and just bring us into the loop, what we would do is say, we think you should call Adult Protective Services, but we are also going to call Adult Protective Services so that there's a sure way that that information is going to get to Adult Protective Services. And on a power of attorney, can I just tell everybody, do not let that get in your way. We're sending the same message to law enforcement. We've heard it from law enforcement. They go into a house, they get a call, the elderly person's being abused, and the next thing you know, son or daughter says, wait a minute, power of attorney. So what? Don't care. It's a piece of paper. If you're abusing it, it doesn't matter. It should not stop your investigation. So way too often people are saying, power of attorney, you need to walk away. The only thing that power of attorney does is gives them some ability to help. It's supposed to be help with the finances. So don't let them do that to you, please. Thank you.
All right. Well, thank you for those of you who meandered back in for this last 15 minutes or 10 minutes or so. Thank you very much. We really appreciate your participation today, and we hope it was a good day for you. I just wanted to ask, just if you'll indulge me, just a couple questions. Could anybody just share what perhaps was the most important or beneficial learning that happened today for you personally? Something that perhaps was an aha moment or something that you feel you could bring back into your clinical practice? Yes.
You know, the old saying is you save the best for last. This was one of the best instruction that we really needed. I mean, I think it's important. I didn't know about your organization. And I work for Seniors Plus, and we refer people all the time. And sometimes we get people and we're just like, well, I don't know what to do. Where do we report it? So thank you very much. That was very informative.
Any other aha moments that people would like to share today? Something special you learned, something you didn't know otherwise, or something that enhanced your learning?
I think Dr. Sano's presentation on the research that's being done, I had no idea that there were things that might even possibly be in the works like that.
I know.
So very good.
Aren't we lucky to have had Dr. Mary Sano to be with us today? We are very, very fortunate. Others? Any other aha moments or something that you particularly enjoyed about today?
Dr. Campbell's talk on the medications and the ones that have been shown to be effective. And that was very interesting and very helpful for me.
Thanks, Elizabeth. Others? Anything that you feel as though you can bring back and implement in your clinical practice almost immediately? Anything? To use one of the screening tools in the annual wellness visit? Great. Which one?
Just one of no, not like one of the actual screening tools, as opposed to like if you get abnormal.
The mini-cog? Okay, great. Anybody else? Anything that you learned today that you can bring back almost right away and implement in your clinical practice setting? Dave, down here. Excuse me?
Fraud.
Fraud. The Effie. That's good. Like the cheat sheet. There's more cheat sheets, a few more cheat sheets up here for folks that would like to have a pocket guide. We do have some pocket guides on elder abuse, investment fraud, and financial exploitation. They're great to use in your practices. And this is the cheat sheet. Anything as we move forward with our programming that you thought in relation to the entire day that worked particularly well for you? I want to ask that question, and then I want to come around and say, if we are fortunate enough next year to receive, we were able to write another supplemental funding award grant. We haven't heard about it yet, but if we do receive it, we will be able to do one more update on Alzheimer's disease training again next year in June. And we would ask if there's anything that could be improved upon from today's event that you would like us to know about as we go forward and make plans for another training next June. So first off, anything you particularly enjoyed about today in relation to just the conference or the training in general that worked well for you? Yes? The location. Okay, good. That's good. That's nice to know. This is the first time that we've been in this venue. We are trying to be good stewards of our funding, and this was a very nice place, I thought, too. Did people agree? Did you like it here? All right, that's great. It's a little confusing. I found it a little confusing with all these doors and entries and exits and whatever, but I think we all did a good job trying to find our way around, and I thank you for your patience. Anything else that worked really well for you today? Was the food okay? Okay. All right, good. Lighting and comfort and tables and chairs and all this and that? Okay. Anything that you'd like us to know about for next year, if we're able to do this again? Anything that would improve what we've done this year? And please, we would like all of your feedback and comments. Elizabeth? Paper for notes. All right, good. Good recommendation. Others? Must be others. Did you?
I think that was wonderful. Sometimes I tend to miss things and
Mm-hmm.
like to be able to kind of preview over, paragraphs.
Great. That's very nice feedback. This is the first time that we've been able to use this. And Sherry, I think you can hear me, perhaps. Thank you very much for all of your attentiveness and captioning. We really appreciate it. Thank you, Sherry. Hopefully she'll respond to us. My pleasure. Our pleasure. Thank you. Anything else? Yes.
On the flyer, it would have been nice to have the actual address and which building it was in.
Okay. All right. Good. All right. That's a very good suggestion. And I know that because we are doing this in concert with the Rural Geriatrics Conference, and they're in a different hotel, that caused a little confusion here and there. And we tried to minimize that as much as possible, because last year we actually had our training over at the same hotel, which was easier for people that were doing both. But this year we moved down the road, and but you all found your way here. But that's a very good suggestion. Thank you. Another question? Yes.
Well, I sort of have a question.
Sure.
You diagnosis, research, and once you've got the diagnosis, maybe next year go down the road somewhat. Now you're maybe 5 years into the disease, maybe have some presenters that take in that.
All right. As the disease advances,
Yes,
what are now the challenges in relation to caregiving, to
caregiving, if you're dealing with somebody in your practice, and as they progress, and some of them will not be able to come into the building or get out of the building. I mean, how
All
do
right.
you
if they can't communicate, how do you find out where are they in pain? How do you find that out?
Sure. Some of the rubber to the road, really down to earth, reality based. Sure. All right. All right. Thank you. Thank you. The other thing I wonder too is about the savvy caregiver, the savvy 1 and the savvy 2. Maybe we could have a little bit more detail about the savvy caregiver program, and because that is really based upon the earlier interventions, and then as someone's disease progresses, trying to help folks with other interventions. So we might be able to go into some more detail in relation to that as well. Another question, yes.
There was a lot of talk about function of a person with Alzheimer's, and I was thinking maybe if you could get occupational therapy view of Alzheimer's as well would be nice.
I think that's a great idea, because that comment came up 2 or 3 different times, and I think that also is correlated to your comment that you just made. So I think to be able to bring in the rehab therapies, and there was an architect who was registered, and I never got an opportunity to see if he actually came or not. And when I asked in our lunch meeting, I didn't see any one hand raised. There was only one architect. But it would be interesting also to be able to get that perspective from, an architectural perspective, from the OT perspective, to see how all of these interventions might be able to address some of what you were saying as well. Thank you. These are very, very good suggestions. Any others? Well, you have our email address. You know where to find us. So if you think of anything else, please send us a comment. And again, we thank you very much. Please leave all your paperwork on the way out, which is the GEC tracker, the evaluation, the CME form completed so that our CME department can get you your certificate, as well as a 3-month follow-up if you would be willing to allow us to send you a 3-month follow-up survey. And again, thank you very much.